like to start to chair, and after that I will present the number 2.
We're doing jointly chairing. Ladies and gentlemen, good afternoon and welcome to this exciting session. A whole afternoon on renal protection, which is obviously fantastic. We've got a long line of experts in the field who have shaped the literature and contributed to our current evidence. So it's great to have this afternoon together. My name is Marlies Ostermann. I'm from London.
Hello, and good afternoon. Michel Slama from Amiens, France. And so maybe, Marlies, would you like to present the first speaker?
I need to take my glasses off. So, Emily. First speaker is Emily C. from Australia, who is an expert in critical care nephrology, talking about the pathophysiology of sepsis-associated renal dysfunction. Emily.
I'd like to start by thanking the organisers for the opportunity to speak to you today about the pathophysiology of sepsis-associated acute kidney injury. These are my disclosures. So, sepsis-associated acute kidney injury is the most common cause of acute kidney injury, and it accounts for more than 50% of severe cases of AKI. Mortality in sepsis-associated AKI is particularly high at 6 to 8-fold non-septic AKI cohorts. Survivors remain at high risk of morbidity, and health services bear a very significant healthcare cost. Sepsis-associated acute kidney injury creates several challenges in understanding the epidemiology, pathophysiology and potential treatments, and that's because both sepsis and acute kidney injury are very heterogeneous clinical syndromes. It was only a couple of years ago that we developed a consensus definition for sepsis-associated AKI, which was published as part of an ADKI initiative. Further challenges include the fact that we've got a very limited understanding of the pathophysiology in humans, so we can't measure renal blood flow easily in humans. We usually don't get tissue because we don't biopsy these patients, and so we end up relying on animal models in the hope that they closely replicate what happens in humans. Even more complicated, the dominant mechanisms of injury in sepsis acute kidney injury are likely to vary between patients, but also within patients along the clinical trajectory. So it's not surprising that there's no effective treatments and outcomes for patients do remain poor despite early recognition and best supportive care. So the mechanisms of injury in sepsis-associated AKI can broadly be grouped into inflammatory pathways with activation of the innate and adaptive immune system, and this is has a secondary injury involving complement activation, coagulation and oxidative stress. Alterations in the micro and macro circulation with variations in renal blood flow and a well-documented dissociation between flow and function. It's thought that dysregulation of the renin-angiotensin system is a key driver to some of this disturbance, and we'll talk about that through this presentation. And finally, metabolic reprogramming with reprioritised energy expenditure, focusing on survival at the expense of function. There's reprogrammed substrate utilisation and restoration of mitochondria. So starting with inflammatory pathways, following the onset of sepsis, damage-associated molecular patterns and pathogen-associated molecular patterns enter the circulation, triggering a systemic immune response. DAMPs and PAMPs are actually filtered across the glomerulus, which activates toll-like receptors in the tubules, creating an additional local immune response. Complement pathways become activated, creating further local inflammation, and activation of the endothelium initiates leukocyte and platelet adhesion, leading to coagulation. And you can see on the right-hand side there's a whole lot of sequelae that occur in the kidney, culminating in ischemia. The The alterations in the macro and microcirculation are largely derived from animal models, but some of them are very familiar to what we see at the bedside. So we see systemic vasodilation, tachycardia, hypotension, and often high cardiac output. At least in most animal models, we see increased renal blood flow. And it appears that the mechanism of increased renal blood flow is catecholamine independent, since there's no effect of noradrenaline on normalising this change, although it does normalise with administration of angiotensin II, linking in the idea that dysregulated RAS signalling is a contributing mechanism. Later on in the course, macrocirculatory changes include renal venous congestion and renal vascular resistance. At a microcirculatory level, there's efferent and afferent arterial vasodilatation, but predominantly efferent dilatation, creating a fall in the transglomerular pressure below the threshold for ultrafiltration, and that's where we get the dissociation between flow and function. Intrarenal shunts have also been described in the context of decreased functional capillary density and potentially shunting directly from afferent to efferent arterioles. It's not surprising that dysregulated RAS signalling is thought to be a component of sepsis-associated AKI, since the angiotensin converting enzyme, which is responsible for the production of angiotensin II, lives on the endothelium, which is often damaged, and polymorphisms of the receptor have also been described. At least in animal models of sepsis, administering angiotensin II in animals with sepsis AKI shows a reversal of, a restoration of function. In terms of metabolic reprogramming, there's a number of events that happen at mitochondrial level. So as we discussed, there's reprioritization of energy expenditure, reprogramming of substrate utilization, and restoration of the mitochondrial pool. So given the diversity of mechanisms that can contribute to the pathophysiology of sepsis-associated AKI, it's not surprising that our traditional approaches, where we've grouped AKI into the cause rather than the mechanism, has meant that we really haven't made much progress in terms of targeted therapies. So there's definitely been a shift in the AKI literature away from an approach where we say, you know, nephrotoxic AKI, sepsis AKI, hepatorenal syndrome, etc. And we go more into the actual mechanisms that are at play. Because as you'll recognise from the bedside, there's a number of septic patients who are febrile, vasodilated with high output shock, who behave a lot more similarly to, say, cardiac surgical patients who've had prolonged bypass runs. And so actually trying to better understand the mechanisms of injury that are at play may then allow us to develop and administer through trials some targeted therapies. So there's now this rationale for the phenotypic approach. And so this is essentially characterising patients into natural clusters, much like what we've seen in some of the sepsis, the non-AKI sepsis literature. And that can be a combination of clinical characteristics, but also biological characteristics through biotypes, and potentially even genetic information through endotypes. There are several potential advantages to this approach. So there's diagnostic value in terms of better understanding the pathophysiology, prognostic value in terms of identifying patients who are most at risk of adverse outcomes, therapeutic value, having targeted therapies for different mechanisms, and finally to allow us to enrich study populations in clinical trials. So there has already been some work done in patients who, in terms of grouping people into phenotypes, and this is one example. So this is a secondary analysis of the ATHOS-3 trial, which was not a sepsis trial, but it was a vasodilatory shock trial, and a number of patients included in the trial did have sepsis. And this group actually, so patients were randomised to, so they had catecholamine refractory vasodilatory shock, and they were randomised to receive angiotensin II or placebo. And this secondary analysis categorised patients according to their baseline renin. So renin's believed to be a biomarker of the function of the RAS, such that high renin through the feedback loop reflects RAS dysfunction. On the left, in patients who had low renin, so presumably normally functioning RAS. There was no benefit with angiotensin II versus placebo in terms of survival. But on the right, in patients with high renin, there's a clear differentiation and survival benefit with ANG2. But we're talking about kidneys, so let's see what happened there. So the authors in this subgroup analysis secondary analysis did report the renal outcomes as well. And like the population with the overall survival benefit, patients who had a high renin who were on renal replacement therapy were much more likely to liberate early with angiotensin II compared to placebo. So secondary analysis, hypothesis generating, but an idea of how we could apply phenotypes in future care. So other groups have looked at subphenotypes. This is specifically in AKI patients rather than general shocked patients. So this group did a secondary analysis of prospectively collected data from 2 trials of critically ill adults with AKI. So the derivation cohort was predominantly sepsis and the validation cohort was from VAST. And they did a latent class analysis to identify and replicate AKI subphenotypes. So they took different variables, they looked at a primary outcome of 28-day mortality, and then they did some secondary outcomes as well. So they were able to classify patients into 2 subphenotypes, so AKI subphenotype 1 and AKI subphenotype 2. And these subphenotypes differed in terms of their clinical and biological characteristics. So subphenotype 2 tended to be a sicker population with a higher creatinine, more vasopressors, more mechanical ventilation, and they experienced worse outcomes than their comparators in subphenotype 1. So here we've got an example of a prognostic subphenotype in the context of sepsis AKI. But one step further than that, they were actually able to look at the response. Actually, I think that's on the next slide. But the response of adding vasopressin to patients from the VAST cohort, and they found that in patients who'd been classified as subphenotype 1, if they got early addition of vasopressin, they experienced improved 90-day mortality, whereas subphenotype 2 had no benefit. So again, slightly more complex than with the renin example, but ways that we can look at grouping patients with similar characteristics to subsequently define targeted care. So the second analysis from this subphenotyping study actually tried to develop some endotype work. So they, for a subset of the patients, they were able to do a genetic mediation analysis, and they found that a particular polymorphism was associated with decreased plasma angiopoietin 2, which made it less likely for patients to be classified as subphenotype 2. So again, there may be some genetic predispositions to different phenotypes. We know already that some people have mutations in their RAS pathway or including in the angiotensin II type 1 receptor, which may make patients more at risk of having a very microcirculatory dysfunction driven phenotype. Unfortunately, it's very infrequent that we do genetic testing on patients with AKI, so there are some large international cohorts, especially in patients with sepsis, that were set up for other purposes, but for which AKI data was collected. And we look forward over the next sort of 3 to 5 years understanding more about how this information could potentially help us better understand the pathophysiology. So we can see from our oncology colleagues that a lot of their decision-making and therapeutics are driven by very closely determined molecular diagnostics. And hopefully, even though it's not necessarily pragmatic at the bedside to do forms of genetic testing, it definitely may help us identify future therapeutic targets. And so looking at sort of gene and protein expression to determine endotypes is something that is realistic in the next decade. From animal models, we can also see that there's a number of different AKI endotypes, so different mutations and polymorphisms through the pathways that are well recognised to be relevant for AKI that may then help us understand why, with a very similar insult, two separate patients can have quite divergent clinical presentations in terms of their clinical status. So bringing that all together, acute kidney injury in sepsis represents a heterogeneous set of pathophysiological processes. There are multiple different mechanisms at play, and those mechanisms differ both between patients but also within patients along their clinical trajectory. These mechanisms can broadly be classified as inflammation, disturbance of or dysfunction of the macro and microcirculation, and metabolic reprogramming. The dominant and contributing mechanisms will vary, as we discussed, but classifying AKI patients into phenotypes as well as endotypes in the future may help us better understand the pathophysiology, identify future therapeutic targets, and guide diagnosis and prognosis for these patients. And it's our great hope that in the future, like with lots of elements of intensive care, a precision medicine approach that leverages advanced knowledge and technologies could help us to guide therapy. Thank you.
Emily, if you just stay for a second. We've decided to take some questions right after the talks,
Okay.
instead of after 4 talks, as it says in the program. So we have time for one question. I can't see anybody. Let me ask you, so you gave a fantastic overview of the complexity of the pathophysiology of sepsis-associated AKI. And you, in your final point, your take-home point, it says here it may guide therapy in the future. How close are we? What do you think? I mean, this is...
Yeah, I mean, we're definitely getting closer with the angiotensin II work. So I think that's going to be something where we've actually got a therapy. We've got a biomarker and we've got a therapy and we've got secondary analyses that suggest that that kind of approach improves outcomes. So we're doing a trial in Australia at the moment looking at angiotensin II compared to noradrenaline, with renin being used as a biomarker. But the issue with doing it in the way that hopefully it will be done is that we don't have real-time results for the renin. So at our centre, renin's batched twice a week, and so you can't use that to choose the vasopressor. But we are getting closer with developing new point-of-care renin testing, and the hope is that over the next 5 or 10 years that may be available, such that if a patient with shock, with, let's say, septic shock comes into emergency, a renin could be checked, and if the renin is high, they could be started on angiotensin II rather than noradrenaline, knowing that with the expensive angiotensin II, you wouldn't want to give it to someone who you think is unlikely to benefit. So using that to guide therapy, I think, would be really exciting, and I think that that's probably reasonable within the next 5 to 10 years in the trial setting.
So I have a short question for you. So thank you, beautiful overview of the pathophysiology. So we used to use amino pressure as the autoregulation for the kidney and for different organs. Which is the role of the diastolic pressure in the pathophysiology of acute kidney injury, for your point of view?
Yeah, so I think it's very difficult in humans for us to really understand what happens to renal blood flow, but also the influence of pressures. But certainly from animal models, we can get more of an understanding about the hemodynamic effects in animals who've been instrumented, and hoping that that will approximate humans. So the mean arterial pressure would be the pressure that's more important in terms of the autoregulation, but obviously the diastolic pressure comes into play there. So, yeah, I think from animal models it's important, but focusing on mean arterial pressures is what we tend to do.
So thank you so much. So I think that we have to move to the next presentation. Thank you again. So I call to the stage Thomas Rimmele from Lyon, France. Thank you for giving a talk on the immune profile of patients who develop renal failure.
Thank you, Michel. Thank you very much for having me here. Dear colleagues, good afternoon. During the next 15 minutes, I'm going to talk about the immune profile of patients who develop acute kidney injury. These are my conflicts of interest. And the outline I'm going to follow, basically I'm going to present 2 studies we've done in our institution. We have completed these 2 studies and about immune alterations in our ICU patients. The first of all is the realism study, and then we have this real acute study, which is a sub-study of the first one. So we started with this pathophysiology of sepsis in terms of immune alterations. You know that sepsis, you have a double inflammatory response with a pro-inflammatory component during the first hours and then an anti-inflammatory component after a few hours. And during the immunosuppression state, after these few hours, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations. And all of this is due to the release of all these mediators that we are going to talk a little bit later. So the question we had in our institution that is this immunosuppression state, is it only after sepsis or is it also in other ICU patients? That's why we launched this realism trial that we published in Critical Care Medicine a few years ago. The primary aim of this work was to assess the immune profile of all our subtypes of ICU patients. We took trauma patients, we took patients coming from the operating room, we took burn patients, we took septic patients, and we looked at this immune profile. And basically we found that they all presented with the same similar profile, with first hyperinflammation and then this severe immunosuppression state. So basically we went from sepsis-induced immunosuppressions to what we call injury-induced immunosuppression. The second thing is AKI. So AKI, we know it's very frequent in our ICU, and we have different studies reporting, epidemic studies reporting the rate of AKI in the ICU, and I think the right number is 75%. In our institution, this is exactly this rate also. We have looked at the rate of AKI. We found the same number as Professor Kellum a few years ago, 75% in Pittsburgh of AKI patients in the ICU. And when you look, and that was, we talked a little bit before with Emily, but basically AKI in the ICU is multifactorial, right? You have hemodynamics, you have inflammation, you have toxic component, you have obstruction sometimes, but the inflammation is very, very important in the sepsis, in the AKI in the ICU, right? And if you look at this, the pathophysiology sepsis-associated AKI that we talked a little with Emily before, but if you look at the legend of this figure, then you look that the inflammation is very important. White blood cells, the DAMs, the PAMs, the cytokines, the chemokines are all involved in the sepsis-associated AKI pathophysiology. We also know that stage 2 and 3 AKI are intimately associated with infection with sepsis, and recently also stage 1 AKI was found to be independently associated with infection following cardiac surgery. So I think it was fair to raise these questions. So first of all, we wanted to look at our AKI patients in all these cohort of patients. We wanted to see the immune profile of these AKI patients. And then to answer this question, is AKI independently associated with this observed initial hyperinflammation? And also if persistent AKI was associated with this injury-induced immunosuppression. So that was the second trial that we just completed last year, published in Critical Care, the real ACI study. So we took, this is a secondary analysis of the first work. We included patients with, so it's adult patients. we had sepsis, defined by the sepsis 3 definition, severe trauma, with an injury severity score of more than 15, surgical patients coming from the operating room, but it was like esophagogastrectomy, bladder resection with breakers, reconstruction, cephalic pancreatectomy, abdominal aortic aneurysm surgery by laparotomy. And also we got severe burn patients with a total burn surface area of more than 30%. So severe patients, right? We excluded, of course, all the patients with the presence of condition or treatment that could interfere with the immune status. And we also excluded patients presenting with end-stage renal disease prior to the inclusion of the first trial. Then we took a lot of samples to all these patients at day 1 and 2, at the beginning, or at day 3 and 4, or at day 5, 6, 7. So we had 3 time points. Why this was not a specific day? It's because we wanted to have the lab, the immunological lab, always open, and it's closed during the weekends. So we had to do this thing to get these 3 time points for all the patients. We defined persistent AKI from the ADKI definition, which is a sustained kidney dysfunction beyond 48 to 72 hours from AKI onset. And then we did a lot of analysis for the innate immune response that was, for example, assessed with the expression of monocytic HLA-DR at the surface of the monocytes, which gives you an idea of, it tells you how the monocyte can present the antigen to the lymphocytes. It gives you an idea of the immunosuppression, because if HLA-DR is very low, that tells you that the patient is very immunosuppressed. We also did some functional testing, and we did some TNF-alpha production after LPS stimulation to assess this innate immune response. And then we also assessed the adaptive immune response with the interferon gamma expression after SEB stimulation. So what are the results? So first of all, we had different groups, and you can see trauma, surgery, sepsis, burns. So we had more AKI, of course, in the group of sepsis patients. But we had less AKI in the surgical group, of course. All the patients who went surgery did not develop AKI. But for trauma and for burns, the rate of AKI was pretty much similar between the 2 groups, AKI and no AKI. And when it comes to organ failures and outcomes, of course, a group of AKI had, of course, more organ failures and worse outcome than the no AKI group. So what's the evolution of this AKI status between the beginning of the study and then after this first week? So in green, you have the patients with no AKI. You can see that almost all of them did not present AKI at day 5, 7. Just like 3 of them developed AKI after a few days. We called this patient the late onset AKI. But in red, you have the AKI patients at the beginning, during the first 2 days. You can see that basically 50% of them still had AKI at the end of the first week. We call these patients with persistent AKI, right? And then half of them recover, actually, from acute kidney injury. When it comes to the measurements of the cytokines, so pro-inflammatory cytokines and anti-inflammatory cytokines with IL-10, you can see that the level of cytokines was higher in the AKI patient as compared to the no AKI patient. That was true for IL-6, that was true for IL-10, and for other parameters. And that was also true at all the three time points. the innate immune response, okay, so monocytic HLA-DR, the expression was lower, even lower in AKI patients. So AKI patients were more immunosuppressed than in the group of AKI patients. AKI is in blue and AKI is in red, and no AKI is in blue, as you can see at the top right, that the expression of HLA-DR is lower in the patients with AKI than with no AKI. Same for the TNF-alpha release after LPS for the functioning testing. The release was less important in AKI patient as compared to the no AKI patient. We found the same results for the adaptive immune response, where the functional testing for interferon gamma expression after SEB was lower in AKI patients as compared to the no AKI patients. Very interestingly, we looked at we stratified the AKI patients based on the KDIGO classification, stage 1, stage 2, and stage 3. And we found that the immune alterations were proportional to the AKI severity. And that was almost true for all the studied parameters. We did some multivariate analysis, and we were able to show that there was an association at the beginning of hyperinflammation with AKI, with some CD10 and CD16 immature neutrophils percentage. And then also at day 5-7, IL-10 and TNF-alpha production after LPS stimulation were independently associated with persistent AKI. The study limits. So we looked at AKI status based only on creatinine level and not with urine output. It was not always possible to get urine output because some of these patients went to the ward and it was difficult. So we took only the creatinine levels. It was a single center study, although we got a lot of patients. It was a cohort of low severity patients because the total mortality rate for all the patients, it was 5%. And we looked at only plasmatic markers. We did not look what happened directly, the direct mechanisms in the kidney. So in conclusion, early AKI is independently associated with the importance of the initial inflammatory response. The presence of AKI at 1 week after injury is independently associated with injury-induced immunosuppressions. The patients who recover from AKI between the initial injury and the end of the first week tend to correct also these immune alterations compared to patients with persistent AKI. And I think a better understanding of this immune profile in the ICU of these AKI patients may help develop specific strategies to improve renal recovery and reduce AKI-related complications such as sepsis. Thank you so much.
Thank you. Thank you, Thomas, for this nice presentation on the findings of the REALIN study. So I have a short. Is there any question from round? Please ask questions. Put some interactivity between us and you. Is there any question? No. So I have a short question. Did you include in the study patient with a previous immunosuppression, like patients with corticotherapy or patients with hematologic problems or something like that? Or did you exclude?
No, that was the exclusion criteria.
Oh, okay.
Everything who could interfere with the immune parameters were, of course, excluded. So patients under steroids or patients with immunotherapy, chemotherapy, stuff like this were excluded. Yeah.
Alice, if you have a question.
Very good. I enjoyed the talk, and the results are clearly very important because, as you said, they may guide therapy. But how do you think how do you envisage the future therapy then for sepsis-associated AKI?
I'm not sure, but we have to take into account. I mean, immunology, I think, in the ICU is going to become very, very important in the future. I think we will do more and more immunological monitoring in the ICU. We will have some tools that will allow us to know where we stand if the patients arrive in the ICU. Are we in the hyperinflammation phase? Are we in the sepsis-induced immunosuppression phase? And I think all of this has to be taken into account in the future of how we are going to deal with these patients. And the therapy that we are going to propose, thanks to the improved knowledge of pathophysiology that Emily reported before, I think we will maybe have to also take into account this immune status to not apply them at the same moment.
But can I just, do you think we will come to a point where we give some immune system boosting medication? Or?
Well, we have there are some trials at this time for immunostimulation in sepsis to try to improve patient outcomes. You can boost the immune system by two ways. You can do it with immunostimulants, interferon gamma, and so IL-7 also, for example, recombinant IL-7. It's possible to boost the immune system. We can also maybe boost the immune system with extracorporeal blood purification. So we have these two possibilities, and to try to get out from this injury-induced immunosuppression, I think it's very important because we know that this immunosuppression is very much involved in the bad patient outcomes, right?
Thank you, Thomas. I fully agree with you. Insight and in-depth knowledge is important to develop future therapies, so this is clearly a step forward. Thank you very much for your exciting talk. Now, before we come to the next talk, I can see there are lots of people standing in the back. Just for information, there are seats here. It'll be more comfortable. Now, the title of this session is Renal Protection, and clearly the best protection if we prevent AKI from the beginning. And Professor Meersch-Dini from Germany is now going to tell us how to do this.
Thank you, Marlies, for the kind introduction. Dear audience, dear chairs, it's a great pleasure for me to talk today about renal prevention. And I would like to show you my conflicts of interest. And this is my agenda. I will first talk about the epidemiology and then go over to the definition and then about prevention. So the incidence of acute kidney injury has been demonstrated in the so-called ACI-EPI study, which has been published several years ago. Among critically ill patients, every second patient suffers from any form of acute kidney injury, and you can see that most of these patients suffer from a severe form of AKI. But if you have a look at the mortality rates, you can see that it dramatically increases with the severity of acute kidney injury. We also have some data from the perioperative setting. So these are data from the EPIS-AKI study, which included more than 10,500 patients undergoing extended surgical procedures. And the incidence rate is slightly different, obviously. Every fifth patient in the perioperative setting suffers from any form of AKI. Most of the patients suffer from a mild form, so I don't know how to get back. Suffer from a mild form of AKI, but nevertheless you see again that the severity stage significantly increases mortality rates. But it's not only the severity stage of AKI that is important, it is even more complex. It's also the duration of acute kidney injury, so we have to differentiate between a transient form of AKI and a persistent form. And the acute dialysis quality recommends to differentiate it at 48 hours. So everything that is longer than 48 hours is a persistent acute kidney injury. And why is this important? A retrospective analysis and also some other studies have demonstrated the impact persistent acute kidney injury has on long-term outcomes. And this year, the retrospective analysis included more than 1 million patients, and they only included patients with a moderate and severe form of acute kidney injury. And you can see that 25% of the patients developed a persistent acute kidney injury, and persistent acute kidney injury increased the risk for several long-term outcomes, such as intra-hospital mortality, readmission, ongoing dialysis, as well as mortality rates. So if we think about prevention of acute kidney injury, we have to prevent obviously any form of AKI because all these have impact on long-term outcomes. So how do we define acute kidney injury? You all know the KDIGO guidelines recommend to use both criteria, serum creatinine and urine output, for the definition of AKI. We have the 3 severity stages, and all these stages show a loss of kidney function. But we also have the stages stress and damage, which cannot be detected by our classical functional markers. And nowadays we have novel renal biomarkers that can detect these so-called golden hours of acute kidney injury, which means that we have an elevated biomarker level, but our classical markers, serum creatinine and urine output, are still in a normal range. And some years ago, this term golden hours of acute kidney injury has been postulated because in this period, preventive strategies might be more effective than obviously if we already have a present acute kidney injury. So what can we do to prevent AKI? We have our KDIGO guidelines, which recommends to implement a sort of bundle, an AKI care bundle, which includes several supportive measures, such as the discontinuation of all nephrotoxic agents, the insurance of volume status and perfusion pressure, a consideration of a functional hemodynamic monitoring, a close monitoring of some creatinine and urine output, the avoidance of hyperglycemia, as well as the consideration of alternatives to radiocontrast agents. And some years ago, we postulated that probably it's worth to look at deciding or to divide the patients being at high risk when they have elevated biomarker levels, because we know these patients have a stress or damage form of AKI, and the kidney function still is in a normal range. So what has been done is that in several clinical trials, sort of biomarker-guided implementation of the AKI care bundle has been tested. And the first one was here, the PREVACI 1 trial, where only cardiac surgical patients were included. And 4 hours after the cardiopulmonary bypass, a biomarker TIM2 and IGFBP7 has been tested. And if these biomarkers were elevated, then the patients were randomized to receive either a strict implementation of the KDIGO care bundle or a standard of care. And by using such an approach, the incidence of acute kidney injury could be reduced by 15%. Following on this study, several other studies followed, such as the Big Pack 1 trial, which was a similar approach, but among abdominal surgical patients. They showed a 13% absolute reduction. Then we had a Quality Initiative in the US showing an 89% relative reduction. And the PREVACI 2 trial, which was actually the PREVACI 1 trial, but in a multi-center setting, also demonstrated a 10% absolute reduction of the moderate and severe forms of acute kidney injury. We are currently awaiting the results of the Big Pack 2 trial, which is a multi-center, a multinational trial, including more than 1,000 patients, and we hope that we will gain more evidence to show that a biomarker-based implementation of the AKI care bundle reduces the occurrence of acute kidney injury. There are some systematic reviews and meta-analysis which included all of these trials, randomized controlled as well as non-randomized controlled trials. This here is the first one, and you can see that the risk of developing acute kidney injury is lower when an AKI care bundle is implemented, and these are the results for all AKI stages. If you have a look at the more severe forms, moderate and severe AKI, again, you have a signal towards reduced risk for acute kidney injury by using an AKI care bundle. The question that raises is whether we truly have to use biomarkers to be effective and to show a significant reduction of AKI. And this has been tested here in this meta-analysis. You can see, first of all, again, that there is a clear signal towards favoring an AKI care bundle and a reduced risk for developing AKI. And here on the top, you see only those studies including a biomarker-based approach. And here on the bottom, those without a biomarker-based approach. You see that there is still an effect if you don't have a biomarker-based approach, but the effect is more pronounced when you use a biomarker-based approach for detecting those patients who are at high risk for developing AKI. Another question that raises is which component of the bundle is truly effective in reducing AKI? Because you can imagine if you regularly measure some creatinine and urine output, this will per se not reduce the risk of developing acute kidney injury. So what we did is that we combined the Pravaki 1 and Pravaki 2 databases and looked for which component has the highest risk for developing acute kidney injury. And you can see here that it's especially hypotension as well as a low cardiac index, which are responsible for the development of acute kidney injury, as well as the implementation of a nephrotoxic drug. You see this here in this individual treatment effect, that the administration of nephrotoxic drugs was a risk factor for AKI. And we also did subgroup analysis actually to divide between those patients who suffered from low mean arterial pressure during the intervention period. And you can see that those with high mean arterial pressure, that these had the lowest incidence of AKI. So another thing another topic that needs to be shown here is remote ischemic preconditioning. Remote ischemic preconditioning is an intervention that consists of short and transient episodes of ischemia and reperfusion to a distant tissue. It is typically performed by a cuff inflation at the upper arm to approximately 200 millimeters mercury for 5 minutes, so to get an ischemia situation. And after that, you perform a cuff deflation and you have a reperfusion. And by repeating this cycle 3 or 4 times, it has been postulated that there might be preventive effects on different organs. And obviously, we were very interested in whether RIPC reduces the incidence of acute kidney injury. And a few years ago, the RENAL RIP trial was published, where cardiac surgical patients were randomized to receive either an RIPC cycle, 3 times 5 minutes ischemia reperfusion, or a sham RIPC procedure, where the cuff was only inflated to 20 millimeters mercury. And what we found is that the incidence of acute kidney injury was significantly reduced by 15%, especially the moderate and severe forms of AKI, as well as the use of renal replacement therapy was significantly lower in the RIPC arm. And what we saw also was we tested again the G1 cell cycle arrest markers, and we were able to demonstrate that those patients having a short and transient increase of the 2 G1 cell cycle arrest markers early after the intervention, that here the incidence of AKI was significantly lower as compared to those patients where such an increase could not be demonstrated. And we also measured high mobility group box 1 protein, which is a damage-associated molecular pattern. And we also saw that there was a significant increase in those patients receiving an RIPC procedure. So the effect seems to be mediated by damage-associated molecular patterns and toll-like receptor 4 receptors, which has been also shown in experimental studies. And a G1 cell cycle arrest seems to be preventive here in this, at least in the results of this study. However, shortly after the RENAL RIP study was published, 2 large randomized controlled multicenter trials were also published, not showing such a renal protective effect. And despite the fact that there were severe trial design differences, one thing that was clearly different was the use of propofol. And we know from experimental studies, as well as nowadays also from human studies, that propofol seems to inhibit this renal protective effect of RIPC. We are not so sure where in the axis of TLR4 and G1 cell cycle arrest propofol inhibits this effect. But this might be the reason for those 2 multicenter studies not showing a renal protective effect. And there are no severe side effects shown for RIPC, so if you have a high-risk patient who has a very high risk for developing AKI, at least you can think about applying remote ischemic preconditioning. And there is a study from last year, a randomized single-center study, including more than 500 patients. And what they did is that they performed RIPC 24 hours before the cardiac surgical procedure. And they showed, although it was performed 24 hours before the surgical procedure, they showed an effect on AKI. You can see that AKI is reduced in the RIPC group, but this effect is mainly resulting from reduced stage 1 AKI. The thing is that in this study, only some creatinine was used for the definition of acute kidney injury, but again, you can see here that the 2G1 cell cycle arrest markers was significantly higher in the RIPC group as compared to the sham RIPC group. So G1 cell cycle arrest seems to be a very important thing here in the remote ischemic preconditioning intervention. Do we have any pharmacological options to prevent acute kidney injury? So this is a systematic review and meta-analysis that included several studies trying to find any pharmacologic option. We have here the first one, sodium bicarbonate. You can see that there seems to be no effects or no benefit for the use of sodium bicarbonate. For statins, there is no clear benefit for the prevention of AKI. Then they looked for N-acetylcysteine. Again, you can see no clear benefit for the use of N-acetylcysteine. And also anesthetics. It was assumed that probably volatile anesthetics might have a preventive effect on the kidneys, but again, you can see here, I mean, there were only 2 studies actually, but no clear benefit could be demonstrated. Then we have some thoughts that maybe dexmedetomidine may have a protective effect because it's a pleiotropic. Dexmedetomidine has pleiotropic effects. You can see here a meta-analysis including several studies actually, and there seems to be a benefit for the use of dexmedetomidine. And there is another meta-analysis also showing a benefit. So currently we do not have a clear recommendation to use dexmedetomidine for the prevention of acute kidney injury, but at least if you use it for other purposes such as weaning or so on, so probably this might be also beneficial for the kidneys. Then we have amino acids. I will not go over through amino acids because Rinaldo will go over through this. We have some currently ongoing trial from the NZEX group about SGLT2 inhibitors, and we will also hear the talk later on about SGLT2. And I would like to conclude my talk. So subclinical acute kidney injury is important, so biomarker positivity without having a functional loss of the kidneys. Non-pharmacological preventive options, we have the AKI care bundle, and the use of a biomarker-based approach seems to be more effective. Remote ischemic preconditioning seems to have protective effect, but you have to be aware that propofol inhibits this nephroprotective effect. Pharmacological options there is currently no recommendation for any substance. Dexmedetomidine might have an effect, and amino acids, you will hear it in the next minutes. Thank you.
Thank you very much, Melanie, for a great overview. Are there any questions from the audience? Could I just ask you a question? So you showed some successful strategies to prevent AKI after surgery, but also showed some strategies or medications that didn't work in various systematic reviews. And at the end of the day, we're still looking. We're looking for a great therapy for AKI. Do you think that is it possible that these successful strategies were only possible because they were applied in a situation where you know the onset of AKI, i.e. doing cardiac surgery or any form of surgery, and in the settings where we don't quite know when AKI starts and when it's developing, it's harder to find a therapy?
Yeah, I guess this is a real big problem because in septic patients, obviously, you don't know when the situation occurs, where the kidneys are damaged. So what you can do And what has been tested is, for example, the use of remote ischemic preconditioning daily in the ICU setting. There are still some studies going on, so we will see what the results are. But obviously, it's even easier to show a clear benefit if you have a certain time point where the damage occurs. In terms of the AKI care bundle, well, I guess that's also it's also important to perform this in the ICU setting. The problem is that we cannot implement the AKI care bundle in our daily clinical routine. We should, but we know that in septic patients, only 5% of the patients are treated with the AKI care bundle. So we need to have any form of awareness, such as the biomarkers, where we know these patients need a more careful you need to look at these patients more carefully because they are at a really high risk of developing AKI. But clearly in other settings, such as the cardiac surgical setting, it's easier to do such studies.
So for a practical point of view, regarding the bundles, why do we not apply the bundles to everybody in the ICU patients? And second question is, do you recommend to do the RIPC for everybody?
So the first question, we should implement the AKI care bundle in every patient, but we know our daily clinical routine. I mean, I go through the ICU and I see the MAP about 45 and no one is there to do anything. So I guess we should, but it's better to have awareness to know this patient is at really high risk and this needs to be carefully considered in this patient. So I guess we have to do it this way. And the RIPC intervention, what did you ask? Sorry.
Are you doing it? Do you advise that we have to do it for patients?
Yeah, so
in
we do it in the cardiac surgical patient cohort. We use a patient enrichment strategy. Actually, we look for risk factors. So if it's a young patient who only has, I don't know, who needs a bypass, so probably we don't do this in this patient. But if we have like with many comorbid situations, a patient who is elderly, so then we perform it in these patients, yes.
Okay, so thank you so much for this beautiful presentation. So we have to move now to the next presentation. Of course, I don't have to present Rinaldo Bellomo from Melbourne in Australia. So Rinaldo, thank you for giving a talk on established place for amino acids.
Thank you very much. So in order to understand whether amino acids have a place in protecting the kidney, you have to understand the concept of renal functional reserve. Renal functional reserve was first described in the 50s, but was really accurately investigated about 40 years ago by Juan Bosch at the University of Washington. And it is a physiological phenomenon that is present in all of us. What happens when you have a protein load by a meal or by the administration of amino acids intravenously, you have an immediate surge in GFR, which can be described here by creatinine clearance or inulin clearance. This is what we do. Presumably, it's here to deal with the fact that we have a protein load, we have an ammonia load arriving at the liver level. The liver generates urea, urea gets into the bloodstream, and the kidney has to get rid of it. And so this is a developed physiological phenomenon by which we respond to that. There are now more than 100 experimental models in humans and animals confirming that this happens in every species, in every mammalian, and of course in human beings as well. And it's a difference between the baseline GFR and the peak GFR after the administration of protein. And the magnitude of the effect is of the order about 40% increase in GFR. And if you study that in detail in animals, like we have done, and this time you administer amino acids and you look at what happens to the physiology of the kidney, you have an increase in oxygen delivery, you have renal vasodilatation, increased GFR of about 45%, and increased oxygenation of the medulla and the cortex, measured invasively with oximetric probes. People have studied what the mechanisms behind this degree of vasodilatation. Obviously, the afferent arteriola must vasodilate. There is production of nitric oxide by nitric oxide synthase. There is release of prostaglandins. and there is inhibition of the tubular glomerular feedback, and all of these mechanisms lead to renal vasodilatation and increased GFR. So can this effect of protein administration or amino acid administration be used clinically to recruit GFR when you want to? Well, the first study to suggest this was done in 1973, when you could publish in the New England with only 53 or 59 patients. And it showed that if you gave amino acids as part of the parenteral nutrition, in addition to glucose, which was what was used those days, there was an improvement in renal function and better patient outcomes. About 10 years ago, we studied the infusion of amino acids in patients that are critically ill, and were able to demonstrate using both creatinine and cystatin C that in the patients exposed to amino acids, there was an improvement in GFR. In patients after cardiac surgery, the Swedes looked at the administration of amino acids and measured renal blood flow and GFR after the administration of a load immediately after cardiac surgery, and demonstrated a significant increase in renal blood flow and GFR. And when you do that in cardiac surgery patients, you can also unmask a degree of renal flow and renal oxygenation delivery dependency, suggesting that there is a degree of oxygen debt that can be improved if you improve renal blood flow. And I could go through all of this. There are multiple studies, all of them positive, all of them showing a benefit on GFR with the administration of amino acids under different circumstances. So it's not a surprise that in this setting, we designed and conducted the protection study, which is a randomized controlled trial of amino acids compared to placebo in patients undergoing cardiac surgery with the purpose of achieving kidney protection. The trial randomized patients that are adults undergoing on-pump cardiac surgery and excluded patients with a very low GFR, people with previous ongoing renal replacement therapy, kidney transplantation, and a whole lot of other relatively unimportant in this population exclusion criteria. We aim to randomize 3,500 patients, of which 1,750 would get amino acids at 2 grams per kilogram of ideal body weight, up to a maximum of 100 grams a day. And the treatment was to be given for at least 72 hours, or until the start of renal replacement therapy, or until ICU discharge. This is the preparation that was used. It's a balanced preparation of 10% amino acids, including pretty much all of the amino acids available in the human body. And I've underlined glycine and arginine because experimentally these two amino acids appear to be the most important vasodilating amino acids for the kidney. The outcome was a KDIGO staging and criteria of stage 1, stage 2, and stage 3 as the primary outcome of effect. And of course, we had a variety of secondary outcomes, which include the duration of renal replacement therapy, the ICU and hospital length of stay, mechanical ventilation, mortality, and quality of life. So what was the trial intervention? Amino acids, infusion rate on average 40 mils per hour, average duration 30 hours, and average dose 1.26 liters. Placebo, which was Ringer's lactate, same dose, same duration, same volume, and you can see how the bottles were blinded. The reason for cessation of the infusion was discharge from the ICU, which was the most common cause for stopping the infusion, and occurred in 3/4 of the patients, and about 20% completed the infusion up to 72 hours. What kind of patients are we talking about? Typical age, as we see, in the mid-60s, mostly boys, baseline creatinine within normal limits, and about 1/3 of the patients had coronary artery surgery, 1/3 had mitral valve surgery, 1/3 had aortic valve surgery, and there was smattering of other operations. The New York Heart Association Class 3 and Class 4 was present in 1 in 5 patients, and the average duration of cardiopulmonary bypass was 1.5 hours. The majority of patients received vasopressor support, with epinephrine and norepinephrine being the dominant agents, and the blood pressure was maintained during the post-operative period to relatively high levels. The primary outcome was the incidence of acute kidney injury, and as you can see there was a 5% absolute risk reduction and a 15% relative risk reduction in the occurrence of acute kidney injury, and this was highly statistically significant. There was also a significant reduction in stage 3 AKI. It was a 44% relative risk reduction in the highest level of injury. We looked at predefined subgroups, and when you look at that in older patients or younger patients, patients with heart failure or without heart failure, patients with evidence of chronic renal impairment or not, there was a similar effect of the amino acids to decrease the incidence of acute kidney injury. Secondary outcomes, there was a 27% relative risk reduction in the use of renal replacement therapy, but the numbers were small and this did not achieve conventional statistical difference. And this is a representation with a Kaplan-Meier curves of the difference between the two groups. Secondary outcomes, use of renal replacement therapy we talked about, the duration was not affected, the duration of mechanical ventilation was not affected, and that's not a surprise. The duration of ICU stay was similar. The duration of hospital stay, there was a trend towards a 1-day decrease in the duration of hospital stay, and the mortality up to 30 days, 90 days, and 180 days was not statistically different. We have conducted a modeling of the cost of this intervention in different countries, and there's an abstract being presented here by Monash University by Lisa Higgins, and it looks like there is a cost benefit in association with the administration of amino acids. Safety data, there were no differences in any of these adverse events that are sometimes associated with cardiac surgery, indicating that amino acid administration is safe. As you always do after a publication of a major trial, you do a meta-analysis of all controlled trials of amino acids in the perioperative period. There were 15 studies, and of these, 6 reported information on the occurrence of acute kidney injury, and the findings support a 44% relative risk reduction with amino acids in the perioperative period. There were also 6 studies reporting the incidence of AKI stage 3, and there was a 45% relative risk reduction in this complication. Then looking at the hospital length of stay, there are 9 studies reporting on the duration of hospital stay, and there is a 1-day decrease in the duration of hospital stay in these patients. We've recently conducted a post hoc analysis focused on patients with chronic kidney disease defined by an eGFR less than 60 mils per minute. This has just been published in Anesthesiology. And this is a significant group of patients of those undergoing cardiac surgery. In our trial, there were 812 such patients. And the amino acid intervention decreased the rate of AKI from 50% to 43%. This is a statistically significant effect, and the number needed to treat is 14 patients. And of course, there is an improvement in eGFR. And there was a similar effect on stage 3, with a greater than 50% relative risk decrease in the incidence of stage 3 AKI in these CKD patients. We've also gone to look at the subgroup of patients that in the perioperative period received mechanical circulatory support. The majority of these patients were receiving intra-aortic balloon counterpulsation, but 27 of these patients were also receiving extracorporeal membrane oxygenation. This population had a very high incidence of acute kidney injury, as you would imagine. In these patients with placebo, the incidence was 60.8%. but with amino acid administration, it was 44.6%. This is near 16% absolute decrease in acute kidney injury, 27% relative decrease, and number needed to treat is 6. And this is the Kaplan-Meier representation of this effect in this particular subpopulation. We've recently also published a review of the pathophysiology, the findings, and the rationale in the Annals of Thoracic Surgery, if you're interested in the details. So let me conclude my presentation that we have overwhelming evidence that amino acid infusion recruits renal functional reserve, increases renal blood flow, and increases renal oxygenation. This is data based on more than 100 experimental studies. We have pilot studies of amino acids, which every time have shown renal functional benefits. We have a large double-blind, multi-center, randomized controlled trial of more than 3,500 patients showing a clear beneficial effect on functional performance by the kidney and a decrease in AKI stage 1 and stage 3. These effects are also supported by recent meta-analysis, which also shows that this intervention is cost-effective. So there appears to be a robust case for the treatment of cardiac surgery patients with prophylactic amino acids to prevent the loss of renal function and decrease the cost of postoperative care. As you might imagine, these findings have now triggered a variety of pilot studies to pursue the agenda of whether amino acids treatment is beneficial in other conditions where there is loss of renal function. Thank you very much.
Thank you so much, Rinaldo. Is there any question from the audience? I think there is one over there. Is there any question? Sorry for... Yes, I can see
It's a microphone.
a gentleman over there. Is there any microphone for...
Just here.
Here, for the gentleman?
Okay.
My name's Sebastian Trop. I work in CVICU. I work in 3 different large hospitals in Canada. And I'm just wondering, given the clear effects of the therapy you present, why is it not more widely used, or is it more used in Europe and not in the States?
Well, the paper was just released in August. So it's kind of sort of 5 months, 6 months. The world doesn't react like this, right? I don't know what people think about this in Canada, and I don't know what they're planning to do or not doing. At the moment in Australia, we are beginning to try and implement this therapy across different units. The response to trials is not instantaneous. It usually takes about, Ashita, 17 years before a proven therapy is adopted. So I'm hoping it's going to be a little bit faster this time, because I'll be dead by then. So it'll be a little bit disappointing. So it takes time for people to respond. And people will have different views and there will all sorts of concerns, but the data looks very strong. Yeah.
Rinaldo, could I ask you a question? So you've clearly shown in studies that amino acids prevent acute kidney injury. We believe the mechanism is recruitment of renal functional reserve. Our colleague and friend, Professor Ronco, showed that a steak prior to cardiac surgery can also recruit renal functional reserve. Would you advocate that patients...
The cardiac surgeons are not going to let us give a steak to their patients.
Can we advocate a large steak prior to any surgery to do exactly the same, i.e. recruiting renal functional reserve and preventing AKI?
McDonald's is going to sponsor us. Look, I think you realize, of course, that's a very nice joke. I mean, you realize that if you do that, you're going to have a temporary effect, and then it will vanish after about 3 hours or so. You need to have continuous recruitment throughout the period when the GFR is likely to be lost. So the rationale for giving the amino acid infusion is to have constant, relentless recruitment of renal functional reserve while the GFR would normally be decreased by the effect of cardiac surgery. So by all means, if you're going to go and have a steak out there, by all means do, but this isn't quite enough. You'd have to have a steak given down the nasogastric tube continuously for 2 days. So I don't think we're going to be allowed to do that.
Okay. What a shame. Are there any other questions? If not, then thank you very much for your contribution. And we go from amino acids to albumin. And Professor Shehabi from Australia is going to explore the role of albumin in renal protection. Thank you.
Good afternoon, and thank you for the invitation to present this data here for you. And thank you, Rinaldo, for setting the stage for the protein impact. So albumin is different to amino acids, and you'll see that in cardiac surgery, we know that hypoalbuminemia is always associated with a lot of badness. So it's kind of like a dose-response curve, whether you look at hospital mortality or whether you look at long-term mortality, or you're looking at acute kidney injury post-operatively. The lower the albumin level, the higher the hospital mortality, the higher long-term mortality, and the higher the incidence of acute kidney injury post-operatively. So it does make sense to do things that will prevent hypoalbuminemia in the context of cardiac surgery. And the rationale for albumin is fairly clear from that point of view. That it's available, and more albumin seem to be fairly desirable in these patients. And in Australia, at least most ICUs, most hospitals have ready access to albumin solutions, and is frequently used for to offset vasopressors, to reduce the vasopressor requirements and the duration of vasopressor needs, and also to minimize post-operative fluid balance. By giving albumin, you're obviously giving a lot less crystalloids to achieve a desired volume expansion in the context of resuscitation. In the case of albumin, there's been 2 trials that's been recently published, one from Canada, where they looked at 4% albumin compared with Ringer acetate solutions when albumin is used for a primary growth bypass and also for post-operative volume resuscitation. They've had it was a randomized trial, about 700 patients in each group, and the population was fairly almost all comers to cardiac surgery, a very low risk population with a Euroscore of 1.7 and a median GFR of about 82. So they're pretty much a bunch of patients who had relatively normal kidney function. And the incidence of post-operative AKI stage 2 and 3 is quite low, just about 3%. The composite outcome for this trial was a bunch of adverse events, and there was essentially no difference between the albumin group and the crystalloid group in terms of the composite outcome of a bunch of adverse kidney events. The HAS-FLARE trial is a trial that was done in Australia. It's you're giving 20% albumin, and I referred to the trial publication about the renal effects of the 20% albumin in this population. A smaller number of patients, about 250, 228 in each group, again with a low Euro score and a mean GFR that is quite high. So they're basically people with normal kidney function presenting for cardiac surgery. The post-operative AKI 1, 2, and 3 is about 20%, and there was no difference between the 2 groups. This study was initially kind of like designed to look at the vasopressor, duration of vasopressor requirements between albumin 20% and using non-albumin solution, given as a fluid boluses in these patients. So you can see that the number of those who had AKI 2 and 3 is also quite low, 15 and 14 patients in each group. But, secondary analysis showed that the 1-week recovery in the albumin group seems to be better in those who received albumin than those who received crystalloids for fluid resuscitation. So while these studies were done in low-risk cardiac surgery patients, the most recent guidelines on the use of intravenous albumin has called for the investigation of albumin solutions in high-risk cardiac surgery patients. And that's pretty much the subject of the study which we conducted in Australia. This was conducted in 6 cardiac centers in Australia and a center in Italy. And the study was using 20% albumin infusion to prevent kidney injury in cardiac surgery patients. They're the Albix AKI investigators, and I take the opportunity to thank them for their contribution to this trial. So the trial design was a pragmatic, it was an investigator-initiated trial. It was randomized, multicenter, open label. And we included patients who were presenting for cardiac surgery and they were at high risk of kidney injury. So we only included those who had a combined operation so that we expect them to have a long bypass time, and also those who are having a surgery on the thoracic aorta, and any patient who is coming to have cardiac surgery where they have a GFR that was less than 60. We excluded those patients who were admitted in ICU more than 6 hours, so we need the albumin infusion to be given within 6 hours post-surgery, and we excluded those who have very low GFR, very low albumin, and those who were dialysis dependent. We excluded those who were on off-pump surgery or those who were receiving extracorporeal or mechanical support other than a balloon pump. Prior consent were obtained for all these patients, and at randomization, we stratified all the population into those who had GFR less than 60 or over 60, and also by site, so that we have a better idea of what's happening at each site. So the intervention group, they've had 20% albumin given at 15 mils an hour, 20 mils an hour for 15 hours continuously. So it was not in response to a fluid bolus or a need for resuscitation. Everything else in the background going as normal for resuscitation, and this was just going in the background as a continuous infusion as a protein load, pretty much like what was done in the amino acid trial. So the primary outcome of the trial was the acute kidney injury within the first 7 days according to the KDIGO creatinine-based criteria. And we looked at that definition also in the group that had GFR less than 60 and those who had GFR more than 60. The secondary outcomes included MAKE 28, AKI 2 and 3, renal replacement therapy, hospital mortality, and we also looked at vasopressor and inotrope 3-day at day 14, just to see what happened, pretty much like what the Hasselflare did. In terms of sample size, we assumed that the control will have about 30% AKI. We figured that we need 620 patients to detect a 10% difference at a 0.005 with an 80% power. The patients we included in the intention to treat analysis are all those who were consented, and we took out all those ineligible patients who were either recruited when they were not eligible but still recruited. The primary outcome was adjusted for site and GFR above and below 60, and we used an adjusted relative risk as the way to assess the primary outcome. So we had also a bunch of pre-specified subgroups, including according to age, diabetes, GFR, pre-op use of ARBs or ACE, or also 6, bypass time, LV function, and site and region. So they're the participants. We've ended up randomizing 621 patients, And of those, there was 281 patients who had a GFR that was less than 60. If we look at the baseline data, they're pretty much well-balanced group in terms of their demographics and also in terms of their severity indices. You can see that their Euro score is quite higher than the previous trials, about 3.2 and 3.3 in the usual care group. We also looked at their comorbidities, and there was pretty much balance across the two groups, with probably just a little bit more diabetes in the usual care group than in the albumin group. We look at the pre-op regular medication preoperatively. It also was quite balanced between the two groups. There was not much difference between the pre-op medication given on the day of surgery. In terms of renal characteristics, you can see that there are about 14% who had GFR more than 90. If you talk these ones out, the GFR in the group in a whole is about 61, which is quite significantly lower than what previous two trials have done. Operative data, they were about 20% just CAGs only, and they're the ones who had GFR less than 60. And there were also aortic surgery, about a quarter, multiple valves. You can see that the bypass time is significantly longer than the previous trials that are presented. Cardiovascular support at endo bypass are also pretty much balanced between whatever agent has been used, and also in terms of intraoperative fluid given, there was also no difference between the amount of fluid given intraoperatively between the two groups. This is the graph for albumin in the first 14 days. You can see that in this group of patients, we managed to essentially raise the albumin level in those patients who received the albumin infusion significantly higher than the routine group across the 14-day observation period. When we look at the safety outcome, it was relatively balanced except for the blood transfusion, where we noticed that there was higher blood transfusion in the patients who in the albumin group than in the usual care group. This is something which was also noticed in previous trials. When we look at the secondary outcomes, there was not much difference between MAKE-28 and also either in those GFR more than 60 or less than 60. In terms of statistical significance, you could look also at mortality or renal replacement therapy or sustained AKI. There was not much difference either. But when we look at the pressors and onotropes, you could see that there is what you could describe as a trend towards a shorter vasopressor time with the group that received the 20% albumin than those that received the usual care treatment. When we come to the primary outcome of the trial, you look at the KDIGO-defined AKI 1 to 3. You can see that in the overall population, there was a higher AKI in the albumin group when compared with the usual care group. When we look at those who had GFR less than 60 or over than 60, you could see that the result was more magnified in those who had GFR that is less than 60, where the difference was about 8+% more AKI in the group that had GFR less than 60. When we look at this in terms of the relative risk, you can see that when you look at AKI 1 to 3, there was a significant increase in the relative risk, adjusted relative risk, in the patient who received albumin in terms of increased AKI. This was mainly driven by patients who had an GFR less than 60, where there is a significant increase in the relative risk, about 14% increase in the relative risk for AKI in this group, in this population. You can see that, you look at it in a graphic fashion, it's quite clear and, confirm that what you saw on the relative risk there. When you look at the predefined subgroup, you can see that there is no interaction among all the subgroups that we look at, and almost in all subgroups, the estimate point stands on the favoring the usual care group rather than the albumin group, whichever group you were looking at. So in terms of a conclusion, In cardiac surgery patients, albumin, whether it's 4% or 20%, seem to have no evidence of significant benefits in these patients. In patients who are at high risk of AKI undergoing cardiac surgery, albumin increased the risk of postoperative AKI, and it also increased the need for blood and blood transfusion. And for that, I think albumin is probably not recommended as a nephroprotective agent after cardiac surgery. Thank you.
Thank you very much for these very important data. The paper and the presentation are open for discussion. Are there any questions from the audience?
Yes, I have a short question. If I were understood, so the difference of albumin was between 33 and 37, so it means almost 10% of difference between the two groups, which is very low difference in terms of albumin. And do you think that this very small difference explain the fact that you increase the risk of AKI in this patient receiving albumin?
Yeah, I don't think that probably is the mechanism of the increased kidney injury in this group. I think probably the mechanism seemed to be that the protein load was given at a time where, number one, the insult has already occurred, and probably different to the amino acid story, where the amino acid was given prior to the insult, the kidney was already prepared for the insult that's coming, while in the case of the albumin, it was given after the insult, and probably the kidney was already had a hit, and the protein load could not, produce that increase in renal reserve that you saw with the amino acid, for example. So I think that probably the effect on renal hemodynamics seemed to be the reason rather than simply the small difference in the albumin level.
So in the same way, did you find any difference in terms of ejection fraction or cardiac output or level of pressures?
Well, in terms of the vasopressors and onotropes that were used post-operatively and intraoperatively, there was no difference between the two groups. We clearly did not measure the cardiac output in these patients. We did not measure the blood pressure in these patients. But the study was conducted in cardiac centers they have large load of cardiac surgery patients, and we would expect that all these centers, they're used to manage these hemodynamics in these patients quite adequately. So, I don't think there probably is a difference between, cardiac output in one place and cardiac output in another place.
So is there any other question coming from the audience? So if not, we will move to the next presentation. Thank you so much for reporting this very nice study. So now I call Ashita Tolwani for the next presentation coming from Birmingham, US, how to best manage the cardiorenal syndrome, which is a big problem in our ICUs.
Absolutely. Thank you for the introduction, and I thank the organizers for inviting me. So we're switching gears a little bit from the previous presentations and focusing on cardiorenal syndrome. These are my disclosures, which are not related to this presentation. So what I hope to achieve in the next 15 minutes is to basically describe the impact and epidemiology of cardiorenal syndrome, the pathophysiology, talk about understanding how to interpret renal function or worsening renal function in cardiac renal syndrome, decongestion strategies, the importance of urine sodium measurement, and then provide a practical decongestion algorithm. So first of all, let's talk about the impact and epidemiology of cardiorenal syndrome. So we know that cardiorenal syndrome is a major clinical challenge and affects up to 35 to 50% of patients hospitalized with acute heart failure. And we know that these patients have a higher mortality and morbidity. The association between acute kidney injury in this patient population is that it occurs in 25 to 45% and doubles their in-hospital mortality. It also leads to longer hospital days, increases the ICU admissions and mechanical support, and it leads to a higher risk of recurrent heart failure hospitalizations and a greater likelihood of progression to chronic kidney disease. So this slide depicts the pathophysiology of cardiac renal syndrome, or CRS. And what this shows, it enhances basically the bidirectional dysfunction in the kidney and in the heart. And essentially there are 3 different mechanisms responsible for causing this cardiorenal syndrome in general. One is essentially hemodynamic alterations. 2 is neurohormonal activation, and the 3rd is inflammation. So what happens with these hemodynamic alterations? You have decreased cardiac output, which leads to a decreased effective arterial circulation, decreased renal blood flow, and this causes, of course, retention of sodium and water in the kidney. Then, of course, you have activation of RAS and SNS, which further causes retention of sodium, water in the kidney, and further congestion of the kidney. Of course, when the kidney has further retention of volume and sodium and water, this leads to further overloading of the heart and then further activation of these systems. So you can see it's a vicious cycle, and you have damage to both organs. You also have inflammation, where you have cytokine release and oxidative stress, which then causes further damage to both organs. And the main reason for having the elevated creatinine in these patients is venous congestion. So we're going to talk about how to improve renal function, or if there's a way to, by relieving venous congestion. So before we talk about therapeutic measures, we have to understand how to interpret worsening renal function in this syndrome. So first of all, remember, or you need to know, that all worsening renal function, not all worsening renal function in the setting of cardiorenal syndrome is harmful. Worsening renal function can be due to true acute kidney injury, which is associated with a poor prognosis, or what we call a functional or permissive WRF, due to aggressive decongestion but not true acute kidney injury, meaning it doesn't have the same outcomes as somebody with true acute kidney injury. So for instance, as depicted in this diagram, you can see that after you have worsening renal function from congestion, that once you try to decongest the patients, those patients with elevated creatinine are considered to have a pseudo-worsening renal function, unlike patients who have a true acute kidney injury secondary to nephrotoxins, sepsis, or other etiologies. This slide shows multiple studies showing that patients who have worsening renal function in the setting of congestion do not have worse outcomes. In fact, they have improved survival. In all of these studies represented here by the arrows, the top line represents predictability of survival, and those are patients who have worsening renal function. This is another study, a post hoc analysis of the ESCAPE study, showing similar findings, and that those patients who had worsening renal function but no congestion, meaning that they've been congested or decongested adequately, have the best prognosis, while those with no worsening renal function but congestion had a worse prognosis, and the worst one, or the worst prognosis in general, were those who had congestion and worsening renal function. So the key takeaway message is that permissive worsening renal function is not harmful when accompanied by decongestion and natriuresis. So now that we established that, what are the decongestion strategies that we use? And of course, we know that first-line therapies is maximizing the loop diuretic. And so essentially what is done is when a patient's hospitalized with acute heart failure exacerbation, intravenous loop diuretics are given, typically at a starting dose about 2.5 times the dose that is given, or their baseline oral dose that they're taking at home. Of course, if you have chronic kidney disease, an increased dose is often required. Studies have looked at whether intravenous dosing of Lasix or furosemide or loop diuretics in general is better than bolus dosing. And the largest study to date is the DOSE trial, which was a randomized controlled trial with 308 patients, and there was no difference in efficacy. This trial also looked at dose, and the higher the dose of these loop diuretics, the more natriuresis and urine output you did have. If you look at a meta-analysis looking at various randomized controlled trials comparing intravenous loop diuretics to bolus diuretics, then there seems to be a trend with higher urine output and weight loss with infusions. The real issue, though, comes when you have diuretic resistance. And in that situation, when you want to decongest the kidney, you need to do sequential nephron blockade. And these are the different therapeutic measures that have been reported in the literature. Thiazides, MRAs, specifically spironolactone, acetazolamide, SGLT2 inhibitors, and what I'm not going to talk about today, hypertonic saline and loop diuretics. And you can see where these different therapeutic strategies, where they affect or how they affect the renal tubule or the nephron based on this slide, where they take effect in different parts of the tubule segment. All right, going on. Let's talk about some of the trials and what we've learned. So this is the chloritic trial that looked at hydrochlorothiazide therapy in patients as an adjunct therapy to patients already receiving intravenous diuretics. This is a randomized trial in acute heart failure patients. And essentially what was done is hydrochlorothiazide was given in the intervention arm in addition to the loop diuretics, while a placebo was given in the control arm. And what this study showed is that there was increased urine output, increased natriuresis, and decreased weight loss that was statistically significant, increased weight loss that was statistically significant in the group that was treated with hydrochlorothiazide. Of note, secondary outcomes such as rehospitalizations and mortality was not changed. And as for adverse effects, essentially there was more hypokalemia seen in the hydrochlorothiazide arm. Let's now look at MRAs. So this was called the Athena heart failure trial, another randomized controlled trial looking at patients who had acute heart failure requiring hospitalization. And in this particular trial, spironolactone was added on to the intervention arm in addition to standard care with intravenous diuretics. And the outcome for this trial was looking at the BNP, or the NT-BNP level, as a reduction as a primary outcome. And what this study showed that there was no difference. There was no improvement in BNP, and essentially there was no improvement in all the secondary outcomes we think about, such as hospitalizations, mortality, etc. But it showed that spironolactone was safe. There was no increased adverse events. Let's now move on to one of the trials that has really stimulated a lot of discussion. This trial occurred several years ago, and it was the Yvoir trial using acetazolamide. Again, another randomized controlled trial where acetazolamide was given as the intervention arm in addition to intravenous diuretics and standard of care. So the way this trial looked is that patients with acute decompensated heart failure and one sign of congestion and an NT-BNP greater than 1,000 on loop diuretics was randomized either to getting loop diuretics, as outlined here with acetazolamide, or their home dose. So initially on day one, they received 2 times the home dose, and the intervention arm received 500 milligrams of acetazolamide. On day 2 and 3, each of the groups has their home dose, but divided twice a day, with the intervention arm given acetazolamide and the placebo arm, or the other arm given placebo. So the primary endpoint was a congestion score, not diuresis or natriuresis, and you can see the congestion score on this slide. And essentially, what was considered to be successful decongestion was with the meeting of this decongestion score, or decreased decongestion score, or congestion score, I should say, within 72 hours without the need for diuretic escalation. And the study reached the primary outcome. Essentially, there was successful decongestion in the arm that was on acetazolamide in both at randomization, 3 days after randomization, and at hospital discharge. And those patients who were treated with acetazolamide had an improved congestion score as compared to those treated with placebo. If you look at the diuretic effectiveness in the patients who were treated with acetazolamide compared to those who were on the placebo arm, acetazolamide definitely caused more urine output and more sodium output. But what's interesting to look at is if you look at day 2, the cumulative diuresis between the acetazolamide arm and the placebo arm was only about 500 cc's. Now, since then, this study came out comparing 3 diuretic regimens in patients with, again, chronic heart failure who were volume overloaded, but this was in the outpatient setting. And this was a crossover inpatient study, weekly treatments of one of 3 diuresis regimens as listed here. IV furosemide with metolazone versus IV furosemide alone at the dose you see here versus IV furosemide and IV acetazolamide. And what this trial showed is if you compare these three diuretic regimens, there was statistically more significant sodium excretion, urine volume, and a weight difference in those treated with a combination of furosemide and metolazone. Next was furosemide and acetazolamide, and the lowest was just furosemide. So potentially this shows you that just using a thiazide diuretic would probably be better or potentially better than using the acetazolamide. Now, I'm going to briefly talk about SGLT2 inhibitors because I know there's a talk right after this regarding that. And SGLT2 inhibitors have become very prominent recently and used in multiple ways on our patients who have nephrology issues and cardiac issues. This was a study, a retrospective study, looking at patients who had decompensated or acute heart failure who were already on diuretics, the effect of the SGLT2 inhibitor. And what this study showed is those patients, after the treatment of SGLT2 inhibitors, had increased diuresis while the diuretic dose remained stable. So yes, it does enhance diuresis. Since then, there have been several randomized control studies looking at the use of SGLT2 inhibitors in decompensated or acute heart failure patients. I have listed the three most largest here in a meta-analysis. So this was a meta-analysis of 3 randomized controlled trials with 1,831 patients, all that in addition to standard therapy, and their intervention arm was treated with an SGLT2 inhibitor. The key outcomes of these meta-analyses show that the heart failure events were reduced by 62%, readmission risk was lowered by 24%, and there was significant reduction in all-cause and cardiovascular mortality, and the benefits were observed within the first 1 to 9 months post-hospitalization. So unlike any of the previous decongestion strategies that I showed, this is the only one that shows really significant reduction in cardiovascular mortality. So before I talk about how to treat these patients, I have to mention the use of the urinary sodium. So urinary sodium measurement has gained a lot of traction lately because it's been shown by checking a urine sodium random within 1 or 2 hours after receiving a diuretic dose. You can titrate the diuretic dose based on the urinary sodium and improves natriuresis and urinary output. There are multiple studies now showing this, but this happens to be a multi-center randomized controlled trial looking at protocolized natriuresis-guided congestion. So these patients came in who had acute decompensated heart failure, and they were either randomized to standard care or to protocolized diuretic response in response to the urine sodium. So urine sodium was measured 2 hours after the patients were randomized, and then based on the urine sodium results, the diuretics were adjusted or doubled in order to create more diuresis. So, with the last few minutes I have, I'd like to put this all together on how to manage these patients. Clearly, decongestion is priority. And so what is recommended to be done based on the literature is this is a nice schematic approach, a pharmacological approach of how to handle these patients. Based on their home diuretic dose, this shows you what to do in terms of the intravenous dose and when to add a thiazide. And it's very important you also measure urinary sodium and urinary output. If the urinary output is greater than 150 cc's per hour, and anticipating an aim of about 3 liters negative in 24 hours, then you maintain the dose. If the urine output is less than 150 cc's an hour, increase the diuretic dose, or if the urine sodium is less than 50, then increase the diuretic dose. This is a nice summary of a diuretic resistance algorithm that can be done for these patients. So once you maximize a loop diuretic, you can then maximize the thiazide diuretic, and then you try to maximize other segment blockade, as we've discussed, whether it be spironolactone, specifically if you don't have hyperkalemia, acetazolamide. There seems to be more benefit in patients with a metabolic alkalosis, and then, of course, now the use of SGLT2 inhibitors, and then finally, plus or minus amyloid or an MRA. And if that doesn't work, I didn't discuss this, hypertonic saline is a possibility. It doesn't show any harm. And finally, as a last resort, ultrafiltration or then hospice. Now, what I want to emphasize is this is the evolving approach to managing acute heart failure. All the trials I've mentioned in terms of decongestion are listed on this slide, and none of them has showed an effect on deaths or rehospitalizations for acute heart failure. The only thing that's been shown to be beneficial is GDMT initiation with ACE inhibitors, ARBs, and of course with SGLT2 inhibitors. So that's what we need to do, is many of these patients, as an inpatient, these therapies should not be stopped, or if they are not on these therapies, they should be started with certain specifications. So in summary, cardiorenal syndrome stems from maladaptive neurohormonal activation with venous congestion as a key driver of the elevated creatinine. Multi-segment nephron blockade is effective for diuretic resistance. I've shown you some of the studies that have been used. It is more effective with measuring a urine sodium. Moderate worsening renal function is acceptable if decongestion is achieved. It does not have the same outcomes as true AKI as we know it. It is important to use natriuresis guided decongestion to optimize therapy, and more focus is on early GDMT initiation to reduce mortality and hospitalizations. Finally, ACE inhibitors, ARBs, and SGLT2 inhibitors should generally be continued in stable patients when they're admitted for heart failure, and the hope would be to decrease the admissions of these patients as they do poorly by initiating these therapies and doing a better job as an outpatient. Finally, future trials should balance decongestion with neurohormonal optimization. So thank you very much.
Thank you. Thank you very much for this talk. And so, is there any burning question from the audience regarding this presentation? So meanwhile, I can start. So, you know, and we discussed that previously, there are many factors explaining AKI in ICU patients. So how do you know that the cardiorenal syndrome is involved in the acute kidney injury of patient in ICU? Do you use a CVP? Do you use the Doppler inside the kidney or inside the portal vein, as it was described with the Vexus? And how do you assess this part of the acute kidney injury?
Yeah, so the important thing is to distinguish patients who have congestion from other causes of acute kidney injury. And so for congestive purposes, using all those parameters you have or skills you have in the ICU are important. CVP, Nexus, everything to really assess the volume status of the patient and try to optimize that. And then essentially reassessment is going to be very important, which I don't see done a lot in the ICU setting, using those tools that we have. Some have asserted that there may be some help in biomarkers too. Patients who have an elevated creatinine in the setting of a cardiorenal syndrome from congestion, studies have shown that NGAL, a marker that usually is attributed to injury to the tubules, is not elevated. And so it's going to be an assessment of using all those that you talked about in tools to make the best assessment.
You know that in ICU patients, sometimes the diuretics doesn't work. So what about doing some hemodialysis in this kind of patient? You didn't speak about that. Which is your opinion?
Yeah, so there's been a lot of studies looking at ultrafiltration in this patient population, multiple randomized controlled trials, and none of them have showed per se that it increases outcome. In fact, the biggest trial done, the CARES study, actually showed that patients who were treated with the regimented diuretic strategy did better. And so at this time, we haven't found the exact patient population that really improves or can improve from ultrafiltration, and so it's really left as a last resort. Now, there is something I do want to mention in terms of blood purification devices. There is an ongoing study looking at the use of the selective cytopheretic device in patients of heart failure, since we know heart failure is an inflammatory condition. And therefore, if we can mitigate the inflammation by using such a device, which immunomodulates essentially white blood cells, then perhaps we can have a better outcome. Those studies are now ongoing in the United States, and hopefully we'll have more information in terms of other ways to mitigate renal injury.
Michael Hessian from Sydney. Could you just comment on the timing of introduction of those of each drug, meaning that you did say that in stable patients you reintroduce the ACE inhibitors and the SGLT2 inhibitors. For us, the SGLT2 inhibitors have a drug instruction saying that you're not supposed to be using them in unstable patients.
I think that's changing now with the upcoming data from these trials showing that what I didn't show is there have been randomized trials now showing when SGLT2 inhibitors were started in the setting of acute heart failure. The trials that I showed were initially in the immediate state of what they needed decongestion. There are other trials that have shown that later on during hospitalization you get the same benefit. So I think that indications for SGLT as we get more information from these trials will change, and we still need to determine what the optimum time to start them in this patient population is. But technically, if the patient's stable in the terms of their systolic blood pressure is not less than 90, their creatinine is not over 50% of their baseline, and they have no other electrolyte abnormalities, those would be the patients I would consider starting those drugs on.
Professor Tolwani, thank you very much. There is more interest, but I'm afraid I have to move us along the program because we've got a few more exciting talks coming up. And before I introduce Professor Pickers, I'd just like to remind the people who've just joined and are standing in the back that there are still empty seats here in the front. So if you want to be more comfortable, please come to the front and join us here. And now it's a great honor to introduce Professor Pickers from the Netherlands, who will follow on from Professor Tolwani's talk and explore SGLT2 inhibitors a bit more.
Thank you very much, Melise, and thank you, the organizing committee, to invite me again. And actually, it's a pretty much, if I can have my slide, a pretty much seamless bridge, because we already discussed these drugs, and I will come back to the questions that were asked just now. So is there a place for SGLT2 inhibitors for renal protection? So the background is that so far, we have to realize that the only classes of medication that have shown to attenuate the decline of renal function are ACE inhibitors and angiotensin II receptor blockers. These are the only drugs that actually prevent the decline of GFR. And most of the evidence was generated in patients with type 2 diabetes. And now we have these new drugs, and we have to get used to these new names of these SGLT2 inhibitors. They were developed as an anti-diabetic agent in patients with type 2 diabetes as they inhibit the reabsorption of sodium as well as glucose in the proximal tubule of the kidney. And so they do so, so this is a co-transport. And then if you block that and you lose more glucose, it has a glucose lowering effect, of course. And so 90% of this is happening in the proximal tubule. This is a process that is actually using oxygen. And so if you block it, it might also have beneficial effects on the kidney function. Hence the name sodium glucose co-transport protein 2 inhibitors. They lower glucose in the proximal tubule, and that means that the extent to what they can do is related to the GFR. So the blood glucose lowering effect is related to GFR, so it's less in patients with impaired renal function. But there are also other effects. It might attenuate renal hyperfiltration and thereby decrease the progression of CKD. And there are also other mechanisms that are depicted here, intrarenal effects and blood pressure effects and diuretic effects that we just heard that might be potentially of benefit in patients without diabetes. And indeed, large trials have shown that if you are comparing this against placebo, in diabetes patients, there is a benefit, but also in patients without diabetes. So this is an anti-diabetic drug that is useful in other patients as well. So the cardiovascular benefits that are being observed have multiple pathways, as you can see on this right part of the slide. And so the therapeutic efficacy of these drugs might not be related to the hypoglycemic effects, but much more to the effects on water and sodium excretion, as Ashita just explained. So at the beginning, of course, safety studies were done, and one of the things was that people were worried maybe about kidney function, and what they showed actually, as you can see, that in the active group, in patients with and without diabetes, worsening of kidney function was actually lower, and as you can see at the bottom, that indeed this was sometimes even borderline significantly lower. So what is happening if you treat patients with a drug like this? In the placebo group, there's a steady decline of GFR over time. But if you treat patients, there is an acute decline, like ACE inhibitors also might have. But then you actually attenuate this decline. So it takes a long time for, and this is in the fact the case in diabetes and no diabetes patients. But mind you, it takes a long time, 600 days, before these lines will cross and then the beneficial effects will be there. So this is not an acute but a long-term effect. So if you look at all the trials together, 25,000 patients, the fact that there's an attenuation of the decline of the GFR means that there's a reduction of the risk of AKI in these patients. And this is the case in all different subgroups, including in patients with heart failure, including patients with different compounds of this group, and if the follow-up is at least 1 year, and also in older patients. And here you can see all these different trials and the significant beneficial effect at the end. Now, very, very importantly, this is not an acute effect, it's a long-term effect. So if you look at the studies that looked for a follow-up for less than a year, it's not reaching significance. But if you have the studies that looked at more than 1 year, then indeed there is this crossover of lines of GFR and the benefit is there. The authors are very careful with their conclusion, and so they say the use of SGLT inhibitors did not increase the incidence of AKI. Well, actually, it significantly decreased the incidence of AKI. So they're very careful, but of course, this is the way you should do it. So the next question then is, would this actually benefit patients that already have an impaired renal function? So chronic kidney disease patients with a GFR of 25 to 75. These patients have less of an glucose lowering effect because of the GFR is already lower, but maybe the benefit is still there. And as you can see, indeed, this is the case. There is a renal specific composite outcome where there is a benefit, but also survival is much better in the patients that were treated. And so in this study, the Data Safety Monitoring Committee recommended stopping for early efficacy after 4,000 patients because there was already a significant effect. And this is even the case in stage 4 chronic kidney disease. Again, a benefit of treatment with these drugs. And as you can see again on the right, even in the patients with a pre-existent GFR of about 25, you see the little drop in the acute phase, but then the decline is attenuated, and then in the end they do better. So again, a benefit even if your pre-existent renal function is really impaired already. Now this is a fun study, I think. So if you are treated with these drugs for a long time and the benefit is there, would it actually matter if you would stop it? Would you actually have increased risk, or would the benefit continue to be present? So what they did here, this was a randomized controlled trial where they prospectively stopped treatment. So you were given a placebo if you were in the stopping group, and you were still receiving active treatment, and then you just continue with what you had. So it's like the opposite of what we always do. And what they found indeed was that there's an acute decrease in eGFR in the ones that stopped treatment, and that in the ones that stopped treatment, the risk of cardiovascular death or hospitalization was increasing again. So these were people that were on these drugs for years, but if you stop it, their risk increases, while this was not the case in the ones that continued the treatment. So chronic treatment is useful. So for intensive care physicians, the question is, of course, and we that was a question already in the previous talk, what if a patient is on chronic treatment with one of these drugs and is admitted to the ICU for some reason? What should we do? And the current guidelines indeed say stop treatment, because we like to stop everything in the ICU and just give norepinephrine back, right? But actually, trials show that the safety is actually excellent also in unstable patients and also in patients that are critically ill. So we have the fact that if you stop treatment, your risk of cardiovascular death increases again, even after years of treatment, and it's safe in critically ill patients. So maybe the chairwoman actually is one of these authors, very cleverly said, well, as it appears to be safe, you could consider actually stopping if there's no clear indication, if the patient is clearly unstable, in shock or metabolic acidosis, etc. You should definitely stop if there's a contraindication in pregnant women, etc., the ones that are depicted here. Clearly, there was no indication in the first place. But you could actually maybe consider continuing this if the patient is admitted for heart failure or if you think there's a risk of cardiovascular death in this patient that is now admitted to the ICU. This is not how it is in the guidelines at this moment, but this is something that we should consider, I think, with time progressing. So my take-home messages are, in the acute phase, these drugs decrease GFR. So that means that the renal protective effects occur after 1 to 2 years. So this is not a treatment of acute kidney injury, but it may prevent acute kidney injury if you have been on these drugs for 1 or 2 years. Termination of these drugs result in an increase in cardiovascular death in non-ICU patients. It's safe in ICU patients. And so far, the guidelines say you should stop treatment if the patient is admitted to the ICU, but I think we should reevaluate this. And as I said, there are things to consider to actually continue or not. So we need to get used to these new names. I depict them here again, but we did it before, and so I end with this.
Thank you very much for a concise summary of the existing data and the controversy. Are there any questions from the audience? I can't see any.
So I understand that if we start this treatment in ICU, so we will have an impairment of the renal function, yeah? Is there any publication or papers demonstrating that in ICU patients?
No.
Or patients doesn't have previously the treatment?
So the acute decrease in GFR is all in stable outpatient, outclinic patients. And so if your patient is in the ICU and AKI was there or just recovery, I would not start it right away because the benefit is only there after
1
year
year
or more. So it doesn't matter if you wait for a month or whatever before you actually initiate it. I think for intensivists, the main question is what to do if a patient comes in with a drug. And as I explained, I think that the guidelines are really conservative and we might discuss that.
But for your point of view, why we don't have to continue the treatment in patients with shock? Which is the pathophysiology behind this point?
I think that's still the fear of there's no data on safety in these patients. And the fear is there that clearance of the drug, PK/PD, might be different in patients with shock. And everybody's always, of course, rightfully so, afraid that in those cases there might be more harm or the risk for harm than the benefit at that moment.
So I think that thank you so much for your very nice presentation. I don't think that we have any question from the audience. Thank you again. Thank you again. So let's move to the next presentation from Lui Forni, coming from Guildford in UK. Is there a place for bicarbonate?
Thank you. I think John Louis has a plan. Peter did say to me on Sunday he sees more of me than his wife. And I think every lecture I've given in this meeting has either been before or after Peter. So obviously it seems we need to see more of each other, Pete. Right. So is there a place for bicarbonate? Bicarbonate has the advantage that it's much easier to say than any of the SGLT2 inhibitors. So that's one good thing, right? So these are my conflicts of interest. None of these are relevant to what I'm going to talk about, but this is one conflict of interest. You can see this is a paper I was on looking at bicarbonate therapy in intracellular acidosis. So long ago, it was in the last century, right? So, you know, I had my own hair and teeth at that stage. So it's quite a while ago. So what we're going to talk about is renal protection, right? So is there really a role for bicarbonate at the bedside to protect our beloved kidneys? And why should there be any role for bicarbonate? Well, some of you are used to this. Now, I make apologies to any apostles of the Stuart philosophy, right? I can be one of those, but invariably, if I go into Stuart's, people just fall asleep, so I won't go into that. So we'll just talk about the standard Scandinavian therapy between acid-base balance and the interplay between the lungs and the much more important kidneys. So is there a role, right? I mean, the difficulty is acidosis one of the causes of acute kidney injury? Does acute kidney injury cause acidosis, which is what we like to think? So is there any badness associated with acidosis per se? Well, these are the proposed effects of acidemia. So you can imagine if you're giving bicarbonate, you're trying to negate these, right? So there's cardiovascular effects, decreased cardiac contractility, decreased fibrillation threshold, decreased sensitivity to catecholamines, etc., etc. And respiratory effects, increased minute ventilation. That's an adaptation to acidosis rather than an effect of acidemia. But certainly decreased cardiac contractility is one that is talked about at length, as is decreased renal and hepatic blood flow. So you can imagine that if your patient became acidotic for whatever cause, then perhaps adjusting the pH to a more normal result would end up in a better place and perhaps protecting your kidneys. Now, in patients with CKD, metabolic acidosis is associated with acute kidney injury. This paper did catch my attention, and the objective of the study was to determine the association of metabolic acidosis with the development of acute kidney injury. And I thought, well, this is quite interesting. Let's have a look at this. And you can see the red line, for those of you who aren't afflicted with myself, which is colour blindness, so I think the red line is the bottom one, is associated with more acidosis and a worse outcome from acute kidney injury. The problem is it's a kind of time scale that we're not really interested in. You can see it goes up to 10 years follow-up, right? So when I first looked at it, I thought it was 10 days, but I realised it was years. So, you know, that doesn't really help us much. So is there any evidence that bicarbonate therapy has an impact on treating acute acidemia? Don't worry, I'm not going to go through the lot, all right? But these are just studies looking at bicarbonate therapy on clinical outcomes, okay? So the first one, Stackpool, long ago, no difference, no difference, no difference, no difference. You can see there's a trend here, right? Maybe some benefit, but this was a Chinese study where there was only an abstract in English, and there's no difference here. So there's not a lot of evidence, and some may suggest that there's harm. This is a paper written by Neil Sony from Chelsea Westminster, who's an excellent clinician and thinker, and talked about the positive effects of acidosis rather than the negative effects. One of the positive effects that's perceived is the fact on the oxygen dissociation curve, and in times of acidemia, we give off oxygen more readily, so the tissues can be in a better oxygenated state. And if you correct that, then you might actually end up in a worse place. As well as that, there are other criticisms of bicarbonate buffering, right? The effect on the bore shift, but also hypervolemia and hyponatremia. You know, if we give loads of bicarbonate, we might end up in a worse place, especially as patients with severe metabolic acidosis and acute kidney injury are often oliguric or anuric. And so we might get ECF expansion, and the development of hyponatremia is almost virtually guaranteed. How we get round that, of course, is to use hemofiltration in cases like that, where we want to give the patient bicarbonate under a controlled environment where it's isoosmotic and isovolemic. So you might be able to give some bicarb, but not too much, and you'll end up falling back on your trusty bicarb. This is the tissue hypoxia argument. But the thing is, much as I'm a fan of Neil Soney, oxygen delivery doesn't only depend on other things. It also on the bore shift, also depends on the cardiac output. And acidemia is viewed as negatively inotropic, and the positive inotropic effects of alkalization actually extend to pH values above the normal. And so you may have seen that at the bedside, where you've treated the pH, the pressures come down, and you see the patient's getting better. Whereas in fact what you've changed is changed the dose response curve. Venous hypercapnia leading to a decline in intracellular pH. This is the paradoxical intracellular acidosis argument. And this was very beloved of anesthesiologists around 10 years ago. And most evidence for this came from isolated or closed animal models, and one particular reference got a lot of traction. So the idea here is that you give a lot of bicarb goes into the cells, you generate CO2 in the cells, pH goes down, your cells are in a worse place, right? Simplistically put. This was the paper in The Lancet by Jim Ritter, who's professor of pharmacology at Guy's Hospital, the paradoxical effect of bicarbonate cytoplasmic pH. I won't go into it in detail, apart from showing you one of the lines from the paper, that treatment with bicarbonate is both illogical and dangerous, right? Illogical and dangerous. So that's pretty, that's fighting talk. What they don't tell you is, of course, the experiment was performed in isolated platelets at a pH of 7.5 and given doses of bicarbonate that would drown an elephant, right? So yeah, it wasn't really directly applicable to the patient. So I'll go back to this paper that I did when I was just a baby and talk about this and show that you can actually show a change in intracellular pH. So these are white cells suspended in buffer, and we have an intracellular dye. So you can see the pH was 7.4, and we gave a large bolus of bicarbonate, equivalent to about 5 litres, and you got a drop in intracellular pH. So it's a real phenomenon. But if you change it to something that looks more physiological, and so you give small aliquots of bicarbonate, you can get an acidosis which then corrects. So it's entirely dose dependent, and you'd expect that, right? So you'd expect if it was due to CO2 diffusion, if you gave a large bolus, you'd have a problem. If you gave it over a longer period, you might not. So anyway, where do we look for guidance, right? Where do we look for guidance to guide us in whether bicarbonate is of any use whatsoever in acute kidney injury? Well, this is the New England Journal Watch. So the New England Journal Watch probably looks at the papers it rejected, right? So this is, I think, an editorial that came up. Sodium bicarbonate helps patients avoid renal replacement therapy. So this was July 2018, so before the event that put us all on hold for a while, and refers to this excellent piece of work by Samir Jabbar and his French colleagues, which looked at sodium bicarbonate therapy for patients with severe metabolic acidemia. So not AKI, right? This was actually the first decent study to look at metabolic acidosis on bicarbonate. Does it actually make a difference? It was multi-center, open-label, randomized phase 3 trial. There were problems with it, but it was by far the best study to date. And this is the evidence before the paper was published, and it said it's been sparsely evaluated. And reviews from experts, like Ritter, had said, don't use it, it's illogical and dangerous, right? And despite that, more than half of critical care physicians used it. So we're told, like, it's really bad shit, and yet we use it anyway, right? So the French actually grasped the nettle and did the study, right? This was their study. You had to have a pH below 7.2, you couldn't have respiratory acidosis, and a bicarb less than 20 with a SOFA score of more than 4, and lactemia. So they were a pretty sick group, right? And then they either were randomized to a control arm or a bicarbonate arm. There are many differences between the English and the French, right? That may surprise you. And one of them is their use of bicarbonate. Just one of them is the use of bicarbonate. So we tend to use 8.4%. And I'd never seen 4%, 0.2% in the ITUs anywhere I've worked. And yet I managed to find some in the obstetric ward. God knows why. But so that's one major difference, but 4.2%. Anyway, I'll cut to the chase. They didn't show any difference significantly in terms of favouring sodium bicarb, although there was a trend towards it, perhaps, apart from in this group, right? In patients with acute kidney injury. This is the Aiken score. Don't really worry about that too much. But people with moderate to severe acute kidney injury seem to benefit. And that's a mortality benefit, right? So it's a secondary outcome. The study's not powered adequately to answer that question. But, you know, if that's for real, then we've got a relatively cheap treatment that's easy to pronounce and, you know, is useful. But this is the other benefit. This is the really important one, I think, that if you gave bicarbonate, you had less RRT use, right? And so from a health economics point of view, as well as the, you know, side effects of being on RRT, you know, it's much cheaper to give a bottle of bicarbonate than it is to put someone on renal replacement therapy. So this is going back to Journal Watch, and they came out with this conclusion: indiscriminate use of bicarb to treat patients does not make sense, right? However, these data support bicarb in the setting of acute kidney injury, and it should be considered as a temporising intervention to avert renal replacement therapy, which is a meaningful, patient-centred outcome, which is for sure, right? So what next? What can you go home with a message? Well, there were loads of data trawls and meta-analyses after this, because as soon as someone sees something like that, they jump to their computer, right? So this was a study from China, effectiveness of bicarb mortality in septic patients. This used the MIMIC-3 database, or MIMIC-3 database, and showed, again, that if you had stage 2 AKI, the pH was less than 7.2, there was a mortality benefit, really quite significant. MIMIC, of course, is very big. In the overall population, there was 1,700, and there was only 250 in that arm. But you can see the forest plot there, significant benefit. And their conclusion was further large randomized controlled trials are needed, etc. This is another one. So this is a scoping systematic review from Rinaldo's group. And it said, given the lack of data on the effects of IV therapy to support its clinical use, you know, more investigation seems essential. Another systematic review and meta-analysis again showed an improvement in survival. So is there a place for bicarbonate therapy? Well, the ICM had 3 editorials where we discussed the pro and con of that. And I'm kind of in the not sure group, right? And I still don't think any robust recommendations can be given to correct metabolic acidosis. But the basic tenet remains that the underlying cause of the acidosis has to be addressed, right? So we can massage the numbers with bicarbonate, or with a high sodium and low chloride fluid, if you're a Stewart fan. And you can correct the pH, but you don't correct the underlying cause. And so the bicarb ICU2 study, unsurprisingly, the French have started that in 2019, and I believe somebody has told me that it's finished, so that's good, so we might be able to see some more results. And that was just looking at moderate to severe acute kidney injury, so powered within that group. So we should get an answer as to A, whether it protects against AKI, but whether it reduces the incidence of RRT. And not to be outdone by our French cousins, we're doing a similar study, Mosaic. Our entrance requirements are slightly less stringent. So we're looking at patients with a pH of below 7.3 and AKI stage 2. And we're currently on, actually we're now on 840 patients, which we've randomised. And so hopefully we'll be finishing in the not too distant future, or at least before I retire. So with that, I'd like to thank you for listening, and I'm happy to take any questions.
Thank you so much, Lui, for this very important presentation. So is there any question coming from the audience for this very important and practical questions that we have every day in the ICU? Yes, please.
You just need to get the microphone.
Microphone over there, please, on right my right-hand side.
They might get trampled in the rush for the door.
Yes, yes, try to do it, yeah.
So that's an interesting question. And I can tell you now that no one will ever do that study, right? Because originally we tried to do it in that group with pH below 7.2. And despite the fact doctors said they're equipoise, none of them did. So when the pH was below 7.2, certainly below 7.15, they just called for the hemofilter, all right? They wouldn't give bicarb, they would just put them on a hemofilter or dialysis, regardless of what they said. So they said they may have had equipoise, and that was it. So when we started our particular study, we recruited 3 patients in 4 months because it just wasn't the equipoise there. I think there's a counter-argument to that, which is, well, actually, why bother waiting till the pH is 7.1 or 7.15? Why don't you aim for homeostasis earlier and to see if you get an improved benefit? And my own view, our mosaic study is blinded, so I can't tell you what the results are. My own view is that I doubt if there'll be a protective signal against acidemia, but I think there'll be a significant reduction in renal replacement therapy. That's what I'm hoping for, and that should be translated to an improvement in patient-centered outcomes, really, because patients won't end up on RRT. That was a very long answer, I apologise, but I agree with you, but I don't think it'll ever be done. Right?
Is there any other question on this important topic, which is practical at the bedside regarding giving or not bicarbonate?
No.
So I think that we have to move. Thank you so much for this beautiful presentation.
And now I'd like to invite Professor Honoré from Belgium to explore the role of medullary oxygenation and whether it makes sense to improve it during vasodilatory shock.
Thank you so much for your very kind introduction. I want also to thank the organizing committee for the invitation. So my task in the next 15 minutes would be to show you how to improve medullary oxygenation during vasodilatory shock. And I have to acknowledge that most of the study I will show you are animal study. There are very few human study, but there is a good reason behind this, as I will show you. So, pathophysiology of kidney microcirculation, sepsis, noradrenaline, vasopressin, etc. What about noradrenaline at the kidney? Friend or foe? Let's see. Urinary PU2 close to medullary PU2?
Possible?
What about vasopressin versus noradrenaline in ovine septic shock? What to think about the Vanish study and the few human study? I'm so sorry. And I will show you a table comparing all vasopressor effect, most, not all, upon the medulla and some conclusion. Now, we know that in sepsis and septic shock, we have a very nasty effect on the afferent arteriole where it is vasoconstriction. And any vasoconstriction on the arterioles here will decrease GFR. And sepsis induces also vasodilation, which is also very bad because you decrease again GFR. It's pretty bad. What does noradrenaline in this? Well, noradrenaline has almost effect on efferent arteriole with, again, vasoconstriction. So, again, it decrease even more GFR after sepsis. Okay. Now, what about vasopressin in the very nice paper from the group of Pierre Hasfar from France? And he showed that vasopressin is inducing a vasoconstriction of the efferent arteriole. And this is very good for the kidney because it will increase GFR. So going upwards, what sepsis does. So I have a bunch, I'm sorry, of animal study, but nice, I have to say nice animal study because they use a pretty good septic animal model, which is an ovine septic shock model. As you know, mice, rats, they are always hypodynamic septic shock, whereas in ovine we have hyperdynamic septic shock, more close to the human situation. And you see here the urine flow, pretty good, increasing in a p-value of 0.004. Gosh. And then creatinine clearance. Oh, it disappeared. 0.2. What's happening here? Right, let's see. Right. They were distinguishing cortical tissue PU2 and medullary tissue PU2. Obviously, what we look for, it's medullary tissue PU2. We don't care so much about cortical PU2. And in open circle, you see that the PU2 went down from almost 40 millimeter of mercury down to 12. Kidney medulla must be almost dying. And you see that there was a parallel reduction in urinary PU2 and a reduction in closed bars and in closed triangle decrease of urine flow. Urinary PU2 is somewhat controversial in the most recent study. Never mind. So, not very good news regarding noradrenaline and medullary tissue PU2. And so they concluded that in conscious sheep with experimental hyperdynamic septic and AKI, there were rapid and selective reduction in medullary tissue perfusion and hypoxia, despite increased total renal blood flow. You know, we are taking so much time and everything like this to measure the flow in the renal artery. What for? Because it's going to be closely to the cortical blood flow. But tell me what study can say that the renal blood flow will say to you what is the medullary blood flow. Most of the time, the renal blood flow is pretty high and the medullary blood flow is pretty low. What to do? Good question. Right. So we had the chance to do the editorial for this, and we have a pig here, and obviously it's an animal. It's pretty easy to measure what we want. So the dose was 0.4 to 0.8 mics per kilo per minute. There was a flow probe in the renal artery, almost always increased. Cortex, even hyperoxemia. And the oxygen probe in the medulla was hypoxemia. We cannot do this in a human, obviously. And the PO2 in the bladder was almost fine-tuning the one of the medulla. Okay. So, what about now comparison between norepinephrine and vasopressin? So here on this side we have renal oxygen delivery in the entire kidney. Oh, the open circle, the closed circle for vasopressin are increased, but p-value, nothing. Then for renal oxygen consumption, again, some increase in closed circle, but the p-value, forget about it. What's happening here? So, well, then they try to delineate again cortical tissue PO2. It rises, but the p-value is nothing. Whereas for the medulla, it rises, but the p-value is significant. So, they conclude, yes, obviously, we have always to be very prudent with the mesenteric flow, although the dose here was 0.03 international unit. And people say to you, well, we'll have a mesenteric ischemia. Well, it's not the case. Look, the mesenteric blood flow is going well. The conductance is going well. So, okay. Now they conclude, okay, in this ovine septic acute kidney injury model, restoration of mean arterial pressure with vasopressin induced a more sustained improvement in renal function than norepinephrine without exacerbating renal medullary ischemia or an hypoxia, with maintaining the mesenteric blood flow. Now, briefly now, I will review the effect of vasopressor. In the paper, it was vasodilatator. It was the Journal of Translational Critical Care Medicine. It's an open access. And, well, for noradrenaline, I would say that for most of the drugs, we have only animal study. I'm really sorry about this. And you will have the full reference at the site of Journal of Translational Critical Care Medicine, because it was too busy to put everything here. So, in bypass cardiac surgery, 0.1 to 0.8 mics per kilo per minute reduction in cortical and medullary laser Doppler flux and medullary PO2. Bad. Septic shock, we showed that from the study of the group of Bellomo, is bad. So, nothing we can do about. Angiotensin II is more complex because in bypass cardiac surgery, there was a reduction of PO2 by 40% at the dose of 9.8 microgram per hour. Not good. When we look at sepsis, the first study was pretty nice because they were improving creatinine clearance and medullary oxygenation. Brilliant. But they did a subsequent study with the same dose as for bypass cardiac surgery, and they had a reduction of 40% in medullary PO2. So we need to wait. Maybe we will know soon, I hope. Vasopressin, I told you already, the beneficial effect in septic shock. It's also the case in bypass surgery at a dose of 3.3 microgram per hour, and at a dose of 0.03 in the animal model as well. In the VANISH study, the RCT comparing noradrenaline to vasopressin as first-line vasopressors, in septic shock, vasopressin led to a lower incidence of RT, 25% for vasopressin, 35% for noradrenaline. Okay, vasopressin seems to be superior. Last slide before the conclusion. In phenylephrine, that's also an animal study, there was no improvement and it was a decrease in medullary oxygenation, so not good at all. Terlipressin was more interesting in the TELIVAP study. In fact, they showed a reduction in the serum creatinine, significant, and for terlipressin, and they did not show any difference in RT with the control group. So, sounds to be a nice synthetic analog that could reproduce what vasopressin is doing. Regarding, lastly, celepressin, in these studies, celepressin comparing with placebo, there was no difference in renal therapy-free days, and so the medication is not that good despite it's also an analog. So to conclude, if I may, Mr. Chairman, vasopressin in terms of pathophysiology has the best profile for the kidney microcirculation, at least if we look to the animal study and one, perhaps, human study. Noradrenaline is worsening the microcirculation and decrease the medullary oxygenation, as well urine output and GFR, again, based mainly on animal study. Urinary PO2 might be a good marker of medullary oxygenation, but we need much more data on this. Vasopressin in the ovine septic shock was superior in terms of urine output, GFR, medullary oxygenation. And we see also the result from a human study on this. And angiotensin II, we need to wait because there are problems with titrating the right dose. Perhaps they can improve medullary oxygenation in sepsis, septic shock. Terlipressin is good, whereas phenylephrine and celepressin are pretty bad. And the last part is the most important part. And the last part is that we need to have a model for human study. There are some models that has been developed using some type of MRI to try to know exactly what is the oxygenation in the medulla part of the kidney. If we succeed in this, then we can make a lot of more assumptions saying that we can confirm that the animal studies are okay, or we can just say, no, they are not. We need to do more. In any case, we need to do a lot. Thank you so much for your kind attention.
Thank you very much for this overview. And again, the presentation is open for discussion. Now, whilst people are thinking, I have a question for you. You outlined the effects of the pressors on the microcirculation in animals with presumably healthy kidneys. Do you think there's a difference between in the effects between healthy kidneys and patients with and kidneys that have CKD? Because I'm asking because a lot of people, increasingly people coming to the ICU have pre-existing chronic kidney disease and they may have altered microcirculation.
Okay, so your question is that you speak about ovine septic model, and you say if the ovine septic model is healthy, have no CKD or AKI, versus CKD.
Yeah.
That's a very difficult question and a very good question. I think in the literature, I'm not aware of a study looking at this type of profile, but it might be interesting because more and more patients in our intensive care unit are coming with CKD. So that would be very interesting to do. I fully agree.
Okay.
Yes, please. The microphone is coming this time. Thank you, lady.
Thank you. Thank you for this excellent talk. One more shortcoming of animal studies, that the initiation of sepsis is sudden and known, and we see the early phase. But this is not the case in the real life in the ICUs. How to extrapolate these data?
You're fully right. All the animal study, we know exactly the time zero. For human study, we never know, except if we have some study with healthy volunteer, like Peter Pickers is doing with endotoxin. That might be something to look at, to have a time zero. But apart from this, I don't see any possibility. You're fully right. Okay.
One more thing, that is that any different in the different focus of sepsis? I mean, abdominal sepsis with increased abdominal pressure, intra-abdominal pressure, and other alteration of circulation. Or can we discriminate, or should we discriminate the different focuses?
No, if we're right, I mean, we have to make big difference between blood sepsis bacteremia with abdominal infection and with pneumonia. They are totally different. And even urine infection is very different. So yes, we have to make a big difference in this. But that's probably the next step. But it's important. I agree.
So it's a really beautiful research. So just for my knowledge, if I have seen that there is some difference between different drugs in terms of PaO2 on the medulla. But is there any relationship between the pressure, mean arterial pressure, and the PaO2 into the medulla? In another way, is there a close and linear relationship, or do you have like a curvilinear relationship on these animals that you are studying?
That's a very good question. In fact, because those sheep lost their autoregulation, there was more a linear curve. But the relationship between the renal arterial blood flow and the medullary blood flow was not present. Okay. So there is still something. We know that there is shunting in the kidney, about 20%. It's probably a reason why we have no more clear relationship between the renal artery and the medullary oxygenation.
So again, oh yes, the last short question, please.
Sorry, and is it a strong coupling between arterial blood pressure, mean arterial blood pressure, and the blood flow? Because monitoring blood pressure is more easier but probably doesn't reflect the real state.
Sure, because if you measure the global blood flow of the patient, I don't know, with an arterial line, you still have to have a correlation with first the renal blood flow and after the medullary blood flow. But there is 20% of shunting in the renal place. So what we discussed before was to say, well, there is a relationship between global arterial mean pressure and pressure in the renal artery, but not above with the medullary oxygenation because of the shunting in the blood, in the kidney, sorry.
So Patrick, thank you so much for this beautiful research. Again, thank you. And so this is my pleasure to call my friend Jacques Duranteau for the next talk on impact on vasopressor on renal circulation and kidney function.
Thanks a lot. So my link of interest. So what is the best vasopressor for the kidney? To be honest, I don't know. And so just to start. What is important for the kidney is to try to get a flow and to try to also to have pressure. Vasopressor could help us to have pressure because pressure induces flow also at the level of microcirculation. So we have to optimize our stroke volume, and when we introduce vasopressor, not only thinking that vasopressor will do everything. We know that at the level of the kidney, each vasopressor had different effect, and it is why it's exciting to test one and the other and to see if maybe a combination could be a smart thing. So I think we have to think like this. So we know that norepinephrine has a preglommerular arterial vasoconstriction, and it improves the blood flow in the renal cortex and the medulla, but the dose-dependent distribution is debated. What about vasopressin? It's a preferential vasoconstriction of the postglomerular arteriole, resulting in an increase in glomerular filtration, and angiotensin II has a stronger vasoconstrictive effect on postglomerular arterial tone than the preglomerular arteriole. So starting by this very theoretical effect, so how we can move? So Patrick tell you that norepinephrine worsens the kidney. Maybe, but I'm not agree. And I will show you some result from our lab. I'm not agree, but I am a little bit modest on this. So it's big, and we induce an hemorrhagic shock. So bad condition for the kidney. And after we test fluid during resuscitation, fluid alone, fluid plus norepinephrine, fluid plus a high dose of norepinephrine. So you can see that when we give fluid alone, we give more fluid than when we give fluid plus norepinephrine. Nothing very genius. And you can see that we dilute less the patient, the animal, when we add vasopressor, norepinephrine, to fluid expansion. And it's very important for a trauma guy because we try to not dilute too much the patient
to not decrease the coagulation factor. So we test the effect at the level of kidney microcirculation. So we measure the O2 tension at the level of the cortex, at the level of the medulla, and we analyze microcirculation using contrast-enhanced echography. And we observe that during resuscitation we have a similar restoration of the oxygen transport at the macro level in the three groups, and considering the O2 tension at the cortex and the medulla, we have the same recovery, even if we use as high dose of norepinephrine. Considering the contrast-enhanced ultrasonography, echo, we measure two parameters. It's time to peak and it's the transit time. And you can see that during resuscitation, we have a similar restoration of these parameters. So similar restoration of the kidney microcirculation. Okay? So no deleterious effect of norepinephrine in the microcirculation. So for me, norepinephrine is really an help for restoration of flow at the level of microcirculation. Even if we give less fluid, we observe the same recovery. And we analyze this animal at day 2. So we pursue resuscitation, and so this is the histological result. And we do a lot of histological analysis, blind, with 3 guys, independently, completely independently of us. And what we observe that, for example, the tubular injury was the same in the 3 groups. So no deleterious effect of norepinephrine. Just. So I'm sure of the result. It's pig, it's not human, but what about human now? So you know this study about low dose of vasopressin in septic patients, and you know that globally there is no improving of the survival in this patient, but you also know that there is 2 groups. And this is very interesting because the less severe septic shock, there is a positive effect of vasopressin. And you can see that it's less septic shock. It's, if you consider the dose of norepinephrine, it's 5 to 14 microgram per minute. It's 0.2 gamma kilominutes. And just remember this. So a positive effect. And if there is a sub-analysis in this study where they consider the effect of vasopressin on the patient who are at risk, it was a classification of referral, of risk of kidney injury, they observe that there is less patient who progress to renal failure or lost when they use vasopressin, and there is a lower rate of renal replacement therapy when they use vasopressin. So it's interesting. And the study of Gordon, so it's a study, it's norepinephrine versus vasopressin, And it's important to consider that it's always low dose of vasopressin. So the primary outcome was kidney failure, 3 days during 28 days period after randomization, and there is no effect on the primary endpoint. But when you look at the rate of renal replacement therapy, there is less renal replacement therapy in the vasopressin group than in the norepinephrine group. So, once again, a positive signal when we use vasopressin. And I like this study because it needs other study to confirm this, but it's a study on after cardiac surgery. So it's vasoplegic shock, and it's interesting because these patients, they are really at high risk of mesenteric ischemia. And when you use vasopressin, many people say, wow, you will induce mesenteric ischemia. And it is true that we have to be cautious about this. And what they observe first that there is a big difference considering the primary outcome. The primary outcome was a composite criteria of mortality and severe complication. And what they observe that about the kidney, there is less AKIN2, AKIN3, and renal therapy replacement when they use vasopressin. And the result was very impressive. And the study from the team of Piracchio, and where they try to implement a reinforcement learning model. I will not be able to explain everything, but they try to find rules to start vasopressin, and we have in different cohorts based on the analysis of different criteria. And what they found is that in the validation data cohort compared to clinician action, the model suggests to start vasopressin in more patients in an early way and at a lower dose of norepinephrine. And the dose is 0.2 microgram per kilogram per minute. So I think it's interesting when you think about the study of Russell. And what they found that if you take in account this model, there is a decrease in mortality. But you can see in the supplementary data that about the kidney replacement therapy, there is also a decrease. So once again, a positive effect of vasopressin. What about angiotensin II? Just to make things short, you know that with angiotensin II, there is also a signal about when they consider patient with acute kidney injury treated with renal replacement therapy, there is a decrease in mortality when they receive angiotensin II, and also it was easier to stop renal replacement therapy when they use angiotensin II. So we are starting now in France randomized controlled trial in liver transplantation, testing against norepinephrine the effect of low dose of vasopressin, and we are looking at the kidney. I will be able maybe in 1 year and a half to tell you the result. So just in conclusion, so vasopressors are useful to support macrocirculation and microcirculation. I think that early administration of vasopressor in addition to optimization of stroke volume could be useful to maintain renal perfusion. And vasopressin and angiotensin II are promising vasopressors for preserving renal function. We need more study. And we have to think about combination of vasopressor. I just want, because I don't know if, no, I'm sorry. I had some slide on rhabdomyolysis for Louis, but they disappear. So thanks a lot.
Thank you. Thank you so much, Jacques, for this presentation, nice presentation. And I'm sure that there are questions for Jacques. Yes, please. Patrick, you will have a microphone. Yeah.
Jacques, very nice presentation. I think it's alluding to what Marley said at some point, that there can be huge difference between different species. Because we show, well, the group of Rinaldo mostly show this on ovine septic shock. You show this on porcine septic shock, totally different. And in the human, it's again completely different, more closely to the ovine septic shock. So there is somewhere a link that we are missing. I am missing it for sure. But how can we reconcile this? I'm just wondering. Because at the end, if you look to the human, you would say, well, it's probably vasopressin that we should use with the preliminary data you have. But how to reconcile different results between the ovine septic shock and the porcine septic shock?
The story is complex, and it's why it's exciting. So the story is complex. I show you the result of hemorrhagic shock because it's a simple model, and there is no bad effect of norepinephrine. But if I consider, for example, hemorrhagic shock in the same model, hemorrhagic shock and rhabdomyolysis, we have huge alteration at the level of the kidney. Okay, so it's a different story. And if I consider sepsis, it's a different story. Why? Because it's not only flow. There is inflammation, there is alteration of the glycocalyx, there is a lot of other things. And it's why it's exciting. Because it's exciting because if we consider a human study only, the story is very complex. There is different patients with different severity. And what is great is that, for example, there is a signal with vasopressin. We don't know exactly what happens, but there is a positive signal with vasopressin. So it's great. We have to move on.
I think we have to reconcile one thing here. It's the session is renal protection. Patrick told us that noradrenaline is damaging and reduces microcirculation and is harmful. And you showed us that noradrenaline is beneficial. So what do I do at the bedside now? What would you like me to do to protect the kidneys in situations, maybe sepsis, or it could be somebody who is post-trauma? What should I do to protect the kidney?
So norepinephrine is not deleterious. It's not beneficial, it's not deleterious. And what could be deleterious is just to give flow without vasopressor, to give flow with a prolonged hypotension. And this could be deleterious for the kidney. Okay. So what is important is to introduce vasopressor very quickly. Is it norepinephrine? Is it vasopressin? So there is good signal with vasopressin. So it could be interesting to maybe, because it's low dose of vasopressin, maybe it could be interesting to combine norepinephrine and a low dose of vasopressin.
Can I? No. I agree with what you said, Jacques. I fully agree. I think that if we want to say something about renal protection at the time we are just now, we don't have enough data, as you said at the beginning, to say which vasopressor we should recommend to protect the kidney.
Yes, but another point, very important, is that we test with contrast enhanced ecography in septic patient with the same behavior about macrocirculation, same dose of norepinephrine, and when we look at the kidney, some kidney were perfect, the microcirculation was perfect, some it was completely stopped. So it's why it's complex, because there is an heterogeneity of patients, and it's not the same a patient who had never had trouble of the kidney and a patient who had, for example, chronic acute kidney failure. So it's different patient. It's not the same in an hypertension patient and a normotension patient. So it's why we miss something to have a good monitoring of the kidney.
Louis?
A kind of general comment, first of all, aimed at Patrick's delineation between the species and humans. The other big problem with transferring animal data to humans is most of the patients I look after are obese, diabetic, right? They're on lots of tablets, and they've had a surgeon interfere with them. Yeah, and animal models don't really reflect that, right? In terms of prevention, Jacques made an absolutely key observation there, that renal blood flow without pressure is almost deleterious. And that was shown in the 1950s, where renal blood flow in sepsis was shown to double, right? But there was hardly any perfusion pressure and the patients died. And in fact, surgeons discovered that rather worryingly. The other thing I say about medullary oxygenation, shunting in the kidney is absolutely essential to protect the kidney against the oxygen load. And so we talk about the oxygen consumption in the kidney, et cetera, and how metabolically active it is, which it is. But it also gets a huge amount of blood flow with a lot of redundant oxygen that it doesn't need. And that shunting of oxygen protects the tissues from unwanted exposure to free radicals and ROS. So I agree completely with Jacques that maintaining pressure and flow is essential. And actually, maybe I kind of lean towards vasopressin, but just look after the patient properly is my protective mechanism.
So we have to leave some time for Matthew now.
Thank you very much for this discussion. I'm sure it will continue during this conference. And now it's a great honor to welcome Professor Legrand, originally from France and now in San Francisco, who will address the question, do patients die with acute kidney injury or do they die from acute kidney injury?
Thank you so much, Marlies. Good afternoon, everyone. Hang on, almost beer time. And last session, actually, we'll try to discuss why it's important to protect the kidney, because what could be the consequences of acute kidney injury. So, and here are my disclosures. So you will see I mean, you are familiar with this kind of progressed knot or HAP knot in a patient where you admit with sepsis, 73 years old, admitted to the ICU for community-acquired pneumonia and respiratory distress complicated by septic shock with stage 2 sepsis-associated AKI, pulmonary edema, fluid overload, and atrial fibrillation. The question here, is there an association or causal relationship between the patient developing AKI and the complication of that patient, pulmonary edema, fluid overload, atrial fibrillation, and that's what I'm going to try to discuss in the next few minutes. Overall, we know that patients who develop AKI have a much more complicated course and much more complicated trajectory. This is a very large database in the US, administrative database, and you see patients admitted to the hospital with AKI have higher risk of rehospitalization, heart failure, sepsis, pneumonia, myocardial infarction, volume depletion, and mortality. 2.6 increased risk of mortality. So we know those patients do worse. And that's true also in AKI, in ICU patients. And here, that data extracted from previous NIH-funded trials in the US looking at patients with acute respiratory distress syndrome. And what we did, we looked at over the last 30 years, all clinical trials of very well collected data, very well formatted data collection. And we look at those trials over the last, let's say 25, 30 years. First of all, the incidence of AKI over time across the trials, earlier trials and later trials. Here, that's the AKI rate, and here is a severe AKI in a bit brighter red. You see, first of all, that the incidence of AKI has not decreased over time and even slightly actually increased over time. But then when we look at mortality, we know patients with AKI most of the time are more severe. But what is the attributable mortality of AKI, the attributable mortality of AKI in that population? That means that if we will take all patients and all patients will develop AKI, what will be the difference with the mortality risk compared to a pseudo population where none of those patients develop AKI? Overall, we use machine learning to match the population, like all patients will have AKI versus none of the patients will have AKI, everything being similar otherwise. And what we found here on the left, that AKI here is severe AKI, and acute kidney disease, it's persistent AKI. Overall, the 90 days excess in mortality attributable to AKI was 50%. That means that for the same patient, having AKI increased the risk of dying by 50%. If you take patient with persistent AKI or acute kidney disease, the 90-day overall excess in mortality was almost 30%. That means that 30% might be attributable only to AKI and not to the underlying severity of the disease, all other things being similar otherwise. So why patients with AKI will die more, all other factors being similar? Of course, they can develop hyperkalemia, metabolic acidosis, once again, edema, fluid overload. I have to be honest, it's still very rare to lose a patient from hyperkalemia. I mean, it cannot account for all the excess mortality we saw in these epidemiological studies. The same of severe metabolic acidosis, might be a small contributor to excess mortality, but obviously there are other factors. And all these factors I just discussed, all those complications I just discussed, actually as a complication of acute renal insufficiency, renal failure, the loss of renal function. And we know that the loss of renal function might be sometimes dissociated from the damage to the kidney. Been plenty of study here. It's an animal study in which the investigator look at bilateral nephrectomy, so that the ultimate loss of renal function, versus ischemia reperfusion, and they look at the gene expression in the blood. And you see the gene expression can be over expressed or underexpressed, but in very different ways between renal failure, bilateral nephrectomy versus kidney injury. And actually, if we try to translate that into clinical practice, that's true that techniques that actually are there to replace the function of the kidney, so renal replacement therapy, have not shown to improve outcomes in our patients. And all these trials, AKK trial, Ideal ICU, Start AKI trials, they didn't show any benefit of mortality. Once again, there were patients with non-urgent indication of acute kidney injury, so not the indication not the complication we discussed earlier. So we are good in treating complications of renal insufficiency, but not in treating acute kidney injury, and those patients didn't benefit. So why? Why those patients develop more complication and die more? One of the explanations, and there have been growing evidence that the kidney injury affect remote organs and can affect other organs and participate to the vicious circle of multiple organ failure. That's a review we wrote a few years ago on the complication on the heart, a little bit of the lung, I'll touch briefly on that later, of acute kidney injury. And there have been also epidemiological data showing that when patients develop acute kidney injury, compared to patients not developing acute kidney injury, they have a higher risk of cardiovascular events within the days and months following the event or the hospitalization. So why patients developing acute kidney injury have a higher risk of cardiovascular events? Several factors. Systemic inflammation, I'll touch on this. Immune cell infiltration, activation of the renin-angiotensin system, sympathetic activation, oxidative stress, endothelial dysfunction. I won't go through in detail through all of them, but clearly animal models, mostly because that was explored in animal models, show various of factors involved into the cardiovascular consequences of acute kidney injury. I briefly mentioned one of those because that was that was done by our group when I was back in Paris a few years ago. Two animal models, ischemia reperfusion or urethral obstruction of the kidney, and we look at the cardiac impact of the acute kidney injury. And we look especially at one molecule, galectin-3, for different reasons, because it's highly expressed in the kidney, in the heart, and there have been association between the heart and the kidney regarding the expression of this molecule. But anyway, what we found that after renal ischemia reperfusion, galectin-3 rises in the blood, in the heart, and was associated with cardiac fibrosis within the days and months after ischemia reperfusion, and blocking this molecule either with knockout or giving an inhibitor, a systemic inhibitor, prevented the cardiac injury after ischemia reperfusion. Overall, long story short, acute kidney injury activated systemic inflammation and recruitment of inflammatory cells from the bone marrow that go to the heart and then express this molecule, leading to fibrosis and cardiac dysfunction. Funny story is that you might not find that very funny, but still, it's a little bit funny for me. When we did bilateral nephrectomy, so as we discussed before, so induce renal failure without inducing kidney damage or acute kidney injury, we didn't find any cardiac consequences. I mean, once again, that's the impact, the damage to the kidney that triggers the cardiac dysfunction and the cardiac damage, but not the renal failure per se. Back to the story we discussed, including the impact of renal replacement therapy. That was in animal models. Of course, when we go a little bit back to human studies, of course, it's impossible to separate kidney injury and kidney failure. But what we can get into is that patients, for example, who develop among 1,100 patients, about 2/3 develop acute, a bit less than 60% develop acute kidney injury during hospital stay and survived. this hospital stay, those patients who develop acute kidney injury had more expression of glycan-3 in the plasma, more biomarker for cardiac injury, ST2, troponin, NT-proBNP, and also higher biomarker of inflammation, IL-6, compared to the patient who didn't develop acute kidney injury during the ICU stay. Also on admission, this molecule again, glycan-3, patient with higher glycan-3 upon admission among 2,000 patients, 2,000 ICU patients. Those patients with higher level of glycan-3 have more risk of developing major adverse kidney events, so being dialyzed, dying, or not recovering from acute kidney injury, and also higher risk of dying in the ICU. So the story, kind of get together pretty nicely between the preclinical model and the clinical data, including epidemiology and biomarkers. We are not the only group showing this. There have been other groups, and of course, glycan-3 is not the only player. There are other players. This one actually exactly the same model as I presented before, exactly the same methodology published in Circulation 2 years ago from a colleague from Strasbourg in France, and actually in this case not glycan-3 but IL-33, exactly the same model. Increased expression of interleukin-33, and when you block this molecule, you prevent the cardiomyopathy after acute kidney injury. Exactly the same results. We know also, and as a clinician, that patients with acute kidney injury are more likely to develop pulmonary edema and to be on a ventilator and to be difficult to wean from a ventilator. There have been, once again, epidemiological studies. And one of the reasons is because the kidney also damage the lung, and very nice studies, mostly from Dr. Fobel in Denver, in the US. A lot of animal studies, damage to the kidney and looking at the lung, and showing that acute kidney injury induces the same systemic inflammation, like we show in our model, and this systemic inflammation activates several factors leading to increase of endothelial permeability in the lung, apoptosis in the lung tissue, and inflammation in the lung tissue as well, meaning that those patients can develop pulmonary edema from a range of contributing factor, from cardiogenic pulmonary edema, we discussed that earlier. Fluid overload, of course, being an overall player because those patients might have positive fluid balance, but also true acute lung injury with increased permeability and increased damage to the lung directly related to the acute kidney injury. I won't go in details of that. Other models being shown also damage to the liver, to the gut, to the brain. Overall, now very large amount of data showing that acute kidney damage, acute kidney injury induce multiple organ injury and probably play a critical role in the vicious circle of multiple organ failure. So my conclusion will be why will renal failure or acute kidney injury will increase the risk of dying. First, as we discussed, sepsis, AKI has that attributable mortality. That patient die with AKI because they are more severe, but also very likely because AKI has a true direct cause to mortality. Is a direct contributor to mortality. Once again, AKI, of course, is a marker of severity, but also is a direct contributor to the multiple remote organ injury. We discussed the heart, we discussed the lung, the other organs, and inflammation seems to play a critical role in this remote organ injury. And I thank you very much for your attention.
Thank you very much for this concise overview. Do we have any questions from the audience? Yeah. Can we have the microphone here in the... Professor Forni from UK.
Excellent presentation, Monsieur. I really enjoyed that. There's one thing, it might be my memory playing up, But didn't a Canadian study show an increased mortality in patients with AKI and AKD? It was cardiovascular causes, but also increased rate of cancer.
Yeah.
Tell us about that.
Long term, yeah, for sure. And for sure, the cardiovascular complications are clearly not the only play. You can imagine that activating or having persistent systemic inflammation play a role in either the progression of underlying existing cancer or maybe developing cancer. Those are epidemiological studies. There might be some. I'm not aware of preclinical studies, but I mean, it will make sense. I would say so it will make sense that you play around with inflammation, that you increase the risk of cancer.
But it's quite an interesting observation.
Totally, yeah.
So, Matthew, thank you very much for this beautiful presentation. So, I have a question for you. So, you shown us that by inducing in mice acute chronic, in fact, chronic renal failure. So you induce few days later some cardiac dysfunction, fibrosis. I know that calcification on cardiovascular calcification as well. But for mice, 28 days is very long, so it means that it is a chronic effect. Now, if you move to the clinical situation in ICU patients, please tell me if there is any study demonstrating that acute renal failure may induce direct effect on cardiac function by assessed by ejection fraction, speckle tracking, or whatever.
Yeah, just a clarification. That was a model of acute kidney injury. That was short-term acute renal ischemia. And the animal completely recovered from their acute kidney injury.
Okay.
And then there was serial factor, but for example, the cardiac function was altered already a few days after the initial insult. And of course, the fibrosis takes a little bit longer to develop, but systemic inflammation, cardiac inflammation within a few hours, cardiac dysfunction within a few days, and fibrosis, yeah, takes a bit longer.
Okay. So thank you very
so
much,
much,
Matthew. Thank you very much to all the speakers. Thank you, Marlies, for chairing this session. Thank you for the participants to this session. And please have some exercise now after 3 hours of not moving anything. So have a good evening.
Thank you so much.
Oh, Marlies. So Marlies, just one thing.
Oh, thank you so much. Thank you. All right. Okay.
Yes, my friend. Very good. Good to see you, Patrick. Right, so a light, entertaining lecture or tutorial for the end of the day. Thank you for taking the time to come and listen to my meanderings. I'm going to talk to you about rhabdomyolysis, which is pretty obvious. The lights just feel like you're being interrogated here. You know, like, I'm sorry, I did it. Anyway, we're going to talk about rhabdo, and there's some questions, so we'll have a bit of interaction. With luck, this is not really relevant, but this is a familiar story, right? So this is something you should all recognise. Not this particular woman, but still. 82-year-old lady found on the floor following a fall at home, right? So that's fairly standard. Uninjured, but she's unable to get up and had been lying on the floor for roughly 18 hours before her son arrived. So the classical long lie, right? She'd been unwell for about 4 days beforehand with a cough and some shortness of breath. And of course, if you're given that history, then you'll ask a few more things of your junior doctors, like, is there a past medical history? Well, she's hypercholesterolemic, diabetic, hypertension, and atrial fibrillation, so all the diseases associated with our so-called first world, right? And a regular therapy, atorvastatin, digoxin, amlodipine, aspirin, and metformin. So all drugs that you would be familiar with. And examining her, she was alert but distressed, clinically dehydrated, whatever that means, febrile and tachycardic. So I'm sure that's a kind of example you've all seen, right? And she was treated for a community-acquired pneumonia with carmoxiclav, which probably caused her collapse in the first place, and initially resuscitated with a balanced solution. This is a blood gas on admission in kilopascals, because I'm European, right? So pH is normal, PO2 is low, PCO2 is normal-ish. Sodium is a little bit high, as is the potassium, and a creatinine is 265. So a hyperkalemia was initially treated with glucose and insulin, which would be fairly standard therapy. And she had an AKI, because we had a baseline creatinine of 110. So she certainly had an AKI by whatever criteria. And her urine dipstick was positive for blood. So here's a question for you. So which of the following biochemical abnormalities is most characteristic of rhabdo? Now, we haven't got the voting thing, so I'll just show them there. So who thinks I can't actually see you. So who thinks hypocalcemia? Okay, hyperkalemia? Good. Can I just say thanks for joining in? Otherwise, I just feel like such a fool. Right? So metabolic alkalosis. Hypophosphatemia or low serum creatinine kinase. So hyperkalemia is the most characteristic early finding in rhabdo, right? So hyperkalemia is a critical complication, because that's the thing that quite often kills people if they're not treated early after trauma. Hypocalcemia does occur, but it occurs following damage, deposition of calcium into damaged muscles. So you can sometimes see that's a later sign where you'll see calcification of the muscles. And metabolic acidosis is common due to presumably or predominantly lactic acidosis. Phosphate is quite often elevated rather than decreased. That's probably a marker of early acute kidney injury. And as you know, CK levels tend to be markedly increased. Sorry, increased, not decreased. But she was also dipstick positive for blood, right? So they said the urine test was positive for blood. So why is that? Right? These are 5 possibilities. The alkaline urine increases a hemoglobin oxidation, gives you a positive test. The dipstick reagents cross-react to myoglobin. Free iron from muscle damage catalyzes the reaction on the stick. Hypoperfusion of the kidney leads to hematuria, or oxidative stress induces glomerular endothelial damage. So the first question was quite easy. The second one you might not find quite so easy. So who thinks A? Okay, right. Who thinks B? Yeah. C, free iron? No takers for that? Hyperperfusion, I presume we're all going to ignore that. And oxidative stress, well, I just put that as a red herring. Yeah, so the dipstick reagents cross-react with myoglobin. And that they detect the peroxidase activity of heme. right? And that's present in both hemoglobin and myoglobin. So if you've got myoglobin present, you'll get a positive dipstick because of that peroxidase reaction. It's the myoglobinuria that causes this positive test for blood, even though it isn't blood. And if you do microscopy, you won't see any, well, you might see a few, but you're unlikely to see any red cells. Alkaline urine doesn't affect it. Free iron can contribute to oxidative damage, but doesn't affect dipstick readings. And the same for hypoperfusion. So that's really quite common. So the junior doctors thought that rhabdo was reasonable, so they measured her creatinine kinase, and that was some 200,000. So that's significantly elevated, together with her acute kidney injury. You can see this young girl put a story in the popular press in the UK, having had some, I don't know, Brazilian butt lift or something I don't quite understand, and ended up with rhabdomyolysis. So our patient has rhabdo. So what we're going to do next? Okay, she's got rhabdomyolysis. So this is a bit of history now about rhabdomyolysis, just to distract you. This is a quail. And why is a quail relevant? Well, the first descriptions of rhabdomyolysis are actually in the Bible. And it's a question of coturnism, which is eating quail affected by particular trace metals and cause rhabdomyolysis. So part of the story is when Moses was leading the Israelites out of Egypt, they pleaded for meat because they didn't have any meat. So a flock of quail came over. Some of them ate the quail and developed black urine and deadly rhabdomyolysis. It's also described where the walls of Jericho come down, and so that probably described an earthquake where people are also described as having black urine. But probably the first description where it's verified, of course, was during the Blitz in the UK in the early 1940s by Bywaters and Beale, who produced their landmark paper in the Lancet. Despite the fact that Bywaters described acute tubular necrosis secondary to rhabdomyolysis, he actually became a rheumatologist and did a lot of work in juvenile chronic arthritis and was a leader in that area, so didn't pursue his interest in nephrology. But that was like the first major studies. Sort of. There's a kind of reporting bias there because it was in England during the Blitz, but actually if you look at the data, there's earlier German papers from World War I which described the pathology of rhabdomyolysis in quite some detail. But because they're in German, they're kind of lost to the system. They don't get quoted quite so much, so you do wonder if there's a World War II bias there. So rhabdo is characterized by a skeletal muscle injury and release of intracellular contents into the circulation. Right? We all know that. And the plasma binding capacity for myoglobin is actually exceeded when you lose around 100 grams of muscle. So up to that, you can kind of bind a myoglobin and get away with it, but more than that, then you start filtering it or not filtering it, and you end up with myoglobinuria. So it's best viewed as a multifactorial syndrome, really. It's not just its effect on the kidney. So if you look at hospital studies, on why people develop rhabdomyolysis, about 60%, so over half, had more than one factor. And the commonest contributing factor was actually drugs, implicating about 46%. So you're going to know the answer to this because I can see you're fairly engaged, but still. Which of the following is most strongly associated with the development of rhabdo? Who thinks A? Who thinks B? Yeah. So atorvastatin is the answer because statins can induce rhabdomyolysis, and particularly with fibrates or drug interactions, you can get spontaneous rhabdo, and the mechanism involves impaired muscle cell metabolism and mitochondrial dysfunction. Do any of you take statins? But you won't admit to. Right? Did any of you take statins to get myositis? Because I did. I was persuaded by a colleague of mine to take statins, and I got a terrible myositis. And became apparent when I was swimming in the sea, so it was a bit worrisome. But I did manage to get back to the shore. My CK wasn't that elevated, but it's quite common. So metformin, as you know, is associated with lactic acidosis, but not rhabdo, and amlodipine don't, and warfarin isn't affected. So the presentation of rhabdomyolysis is very variable. I'm sure you're all aware of that. It ranges from mild muscle pain. So if any of you have exercised too vigorously or done a half marathon without adequate training, you'll identify with that. And the diagnosis is usually suggested by history and confirmed with an elevated CK. And this myoglobin release plays a pivotal role in the pathophysiology. So causes, well, direct muscle injury, crush injury, ischemia, reperfusion is like the classic, as is the long lie in this case. Electrical burns, over-exercise, you do see occasionally. I've seen it in over-exercise in steroid abuse as well. Congenital causes are also common. And there are some systemic causes which are associated with rhabdo, so drug use, sepsis, you can see it, as well as viral infection and extremes of temperature. And we've all seen raised CK and myoglobinuria with prolonged seizures, but I haven't actually seen rhabdo myself. This is another way of describing the causes, genetic as well as acquired. So there are quite a few mitochondrial cytopathies that can be associated with the development of rhabdomyolysis. So this is a paper looking at the incidence, etiology and outcomes in a single tertiary referral centre. And you can see that the overall incidence of rhabdomyolysis was not high. 93 patients in 140, I'd admitted. But the incidence, interestingly in this group, because it's from Korea, associated with acute pesticide intoxication was the highest. So something that those of us who work in Northern Europe certainly wouldn't see, but there are causes of rhabdomyolysis throughout the world that differ. This is another clinical and epidemiological study. This is from China, and this showed that about half the cases were due to a single cause, which strenuous exercise, drugs and poisons were included, but in most cases, about half cases, there were multiple causes. ICNARC is our intensive care national audit research centre, and we collect something called the case minutes programme. So around 95% of ICU admissions in the UK are entered into this database, so it's a phenomenal resource. I think they have over 1 million patients in the database now. And they looked at some of the cases historically, 733 admissions, so not many in terms of ICU admissions, but 75% were male, median age was around 55, but a significant in-hospital mortality. So it doesn't happen often, but it is associated with a significant mortality. So what do we know, right? What do we know about rhabdo and the pathophysiology and how to treat it? Well, we know there's a mechanical stress, followed by membrane injury, promotion of inflammation, and cell death. So this is a cartoon from one of our reviews on rhabdo. So you can have various causes, infection, trauma, burns, etc., muscle damage. And then this release of myoglobin is the key pathophysiological event that leads to renal dysfunction, tubular damage, and inflammation. Of course, muscle damage itself can also induce systemic inflammatory changes. On a more cellular level, right, you get initial ATP depletion, and so you get sodium, potassium, ATPase dysfunction. The sodium calcium exchanger increases your intracellular calcium within the muscle cells. You can't pump your intracellular calcium out because your mitochondria have effectively turned off. You activate your proteases. Calcium overload disrupts the mitochondria, leads to apoptosis, cell death, and muscle cell necrosis. So this is what happens. And then when you injure your muscles, you may have seen this practically, that they can sequester huge amounts of fluid. So injured muscles can sequester up to about 10 to 12 litres of fluid in a few days. So if you've looked after these patients, you'll be aware of this, third spacing that's quite dramatic. And if you're not careful, then what you'll end up with is a compartment syndrome, calling these orthopedic surgeons, and it all goes wrong. Right? So following injury, myoglobin concentrations rise. But if you've got normal renal function, you can clear those quite quickly, and so your circulating levels may actually decrease within the first 24 hours. But when the myoglobin concentration goes up again and exceeds the resorbing capacity of the kidney, then you get myoglobinuria. So myoglobin in the blood might not be reflected in the urine initially, but then when you get above the resorbing capacity of the kidney, you'll see it in the urine. And that's the classic myoglobinuria. And as you can see, it doesn't only affect humans, it affects animals also. It's classically known as Coca-Cola urine, and you can see there that that could just about pass for Coca-Cola. I think you'd not want to drink it, of course. So the associated acute kidney injury is multifactorial. Right? There's a vasoconstrictive element, hypovolemia, particularly due to the sequestering of fluids, direct myoglobin toxicity to the tubule, as well as cast formation. So this direct cytotoxic effect is actually quite important. So here we have our muscle damage. That's the tubule. You get volume depletion or tubular damage, decreased renal blood flow, activation of your RAS system, renal vasoconstriction, which can lead to ischemic injury, but also you get a direct effect on glomerular function and direct myoglobin toxicity within the tubule. Something called the Fenton reaction there. Fenton was my scientific grandfather. My PhD was in fast reaction chemistry, so I did a lot of this kind of free radical stuff. That leads to oxidative stress, damage to the tubule, and further renal injury. So we think that myoglobin is actually the key damaging element. And in fact, what that shows there is that in the tubule you can get myoglobin attached to the TAMS-Horsfeld protein complex, and you get that with casts within the cell. So, this is a slightly different case, a 45-year-old, unconscious after a prolonged seizure with a CK of 15,000. He's got high potassium and myoglobinuria. What's the next most appropriate step? So who would give him IV bicarbonate and mannitol? Maybe. Okay, some intravenous fluids and urine alkalization. Right, that's a kind. It's interesting. This one is less dramatic than the other questions in terms of answer. Calcium glutamate for hypocalcemia. Right. Hemodialysis for everyone. Or immediate fasciotomy. I think that's a bit extreme. So really, intravenous fluids and urine alkalization is the first port of call in terms of treatment. Importantly, I showed you that despite the fact myoglobin or rhabdomyolysis is a very important problem, your randomized controlled trials and actual evidence in terms of treatment is fairly lax. So aggressive fluid resuscitation is certainly the cornerstone of management, and alkalization of the urine early can prevent myoglobin precipitation. So the PK of myoglobin is around 4.8, 4.9. So if you can get the urine pH to above 7.5, a significant amount, 99% of your myoglobin is going to be ionized, and that's soluble, so you'll pass that out. Of course, that all depends on the load of myoglobin to the kidney. So if you've got huge muscle damage, then that's actually not going to help. That all makes kind of good sense, but as I said to you, there's really a lack of real evidence for that approach. There's no controlled trials against standard therapy. Okay? Mannitol and bicarb were historically used, but there's no strong evidence for that. And in fact, mannitol can run into problems. Calcium gluconate, it's symptomatic hypercalcemia, that should be. And dialysis is only for refractory hyperkalemia. So, with our patient, we continue goal-directed volume replacement. We've alkalized the urine, but our renal function continues to deteriorate over the 48 hours. So she developed fluid overload and anuria. So would you consider renal replacement therapy at this stage? What do you think? Yes or no? Yeah, I think most people probably would. And so which of these findings would strongly indicate the need for emergent dialysis? So who thinks A? Who thinks B? C, it's American data. D or E? So just again, A, not many. B, so acidosis, some. Rising creatinine? No, good. Myoglobin persistent oliguria? Yeah. So that's probably where you'd be looking at to intervene, all right? So you've got persistent oliguria, and what is there is full of myoglobin. I often wanted to do a psychological analysis of people's ringtones to see if it relates to their personality. So if that one relates to yours, you sound like quite a cheerful person, so well done. Mine's a slightly depressing Joy Division song, but that's another indication. Right, so myoglobin with persistent oliguria. So the indication for emergent dialysis is really, refractory oliguria despite fluid resuscitation. Right? So there you've got a myoglobin-induced AKI. Hyperkalemia, of course, is concerning, but really it's only potassium above 6.5, so the classical indications for renal replacement therapy. Acidosis, you may have heard me earlier saying can be managed medically. And rising creatinine per se is not an indication for dialysis. Right? So there are various reviews on prevention of kidney injury following rhabdomyolysis, but not that many with any help. And so this one here says, no evidence supported a preferred fluid type or that bicarbonate with or without mannitol was superior to fluid therapy alone. This is in the Annals of Pharmacotherapy. So we know, I have told you, that myoglobin is fundamental in the development of rhabdomyolysis. So if we could remove or have early and effective reductions in myoglobin, it may be that we can prevent AKI or at least shorten its duration. So the therapeutic intervention so far, as I've told you, focused on fluids, urinary alkalization, and in some cases, diuretic support to retain tubular flow. So retain tubular flow and a pH to reduce precipitation. But an alternative approach might be to remove your circulating myoglobin through extracorporeal techniques. So if you haven't got that, then fluid resuscitation, alkalization, that's all you've got, right? And then dialysis if you need it. But if the myoglobin level is high, it may be that intervening earlier may be of interest. And this is quite a recent approach. This is using the cytosorb absorber, which absorbs myoglobin quite avidly. This is a pooled data on 12 studies on myoglobin and a further 9 studies on creatinine kinase, and shows the effect of cytosorb treatment on myoglobin levels. And these are really significant myoglobin levels of around about 25,000 there. So you can see that use of an extracorporeal circuit can have significant improvements in terms of your myoglobin levels. And of course, what you're going to ask me now is, does that translate to benefits for the patient? Well, we'll get to that. So this is a propensity scoring analysis looking at cytosorb. And so this looks at patients with CKRT and with rhabdomyolysis. 95 patients, 55 were treated with cytosorb and 40 weren't. And what was found was a group 1, the cytosorb treated patients, showed a reduction in myoglobin, which wasn't evident in the standard CRRT therapy. So these are all patients that needed dialysis. But if you look at the longer term outcomes, right, on this, the black line is death. So this is the initial study. But if you look to the 2 columns to the right, green is kidney recovery at day 30, right? And red is ongoing need for dialysis. So the application of cytosorb in this group ended up with a far lower incidence of need for dialysis. So in terms of patient-centred outcomes, that's really quite important. And so the application of a treatment where you could reduce the myoglobin levels early was reflected in a patient-centred outcome that was improved. Would you expect an effect on mortality? Probably not, but an effect on the continuous need for KRT is quite useful. These are the patient characteristics. There was nothing too surprising about those. So this is another prospective trial looking at myoglobin absorption and the saturation kinetics, because what's quite important is in the same way that your kidney gets saturated with myoglobin and you end up with a myoglobin precipitating, the absorbers are the same. They have a limited half-life, and the cytosorb absorber eliminates myoglobin very effectively, but the absorption capacity decreases after about 3 hours. So it may well be for effective treatment, you need to be measuring your myoglobin and considering changing it earlier than you would a standard procedure. So this has triggered a consensus conference examining the role of hemoabsorption in rhabdomyolysis. This was the task force. There was various of us involved in that, and these are the representatives. And our aim was to produce best practice consensus statements for hemoabsorption in this group. We looked at eligible studies up to 2023, online conferences were held, and we devised various questions and then went through the Delphi process. I won't bore you with the whole thing. If you want to read it, it's published in Journal of Nephrology. But the main areas of disagreement, unsurprisingly, were on the timing of hemoabsorption treatment, the various cut-offs you might use, and whether you would use it as a standalone treatment rather than in conjunction with renal impairment. So this was the first statement, and we said that myoglobin contributes to the development of AKI, with raised levels associated with the risk of developing rhabdo. And certainly, a Bishan serum at myoglobin development of acute kidney injury is well established. This is the AUCs of myoglobin and CK, and you can see myoglobin is a better predictor of the outcome, and certainly admission myoglobin better predicts the development of AKI. And so if we're thinking of treating patients early, then perhaps we should have a system where we could measure myoglobin. Patients with myoglobin above 10,000 should be considered as high risk, and so they would be likely to develop severe secondary dysfunction. And so in those group, perhaps that's where you should consider extracorporeal treatment, because reducing circulating levels may translate into a benefit. As I've showed you in that earlier study, there's less dependence on RRT. Conventional treatment doesn't significantly eliminate myoglobin, whereas hemoabsorption can. And of course, certain filters, higher cutoff, you will see some myoglobin spillover. And if you can't measure myoglobin, then hemoabsorption can still be indicated based on the clinical picture and the CK. We don't know how long for, and we suggested that the cartridge be replaced every 8 to 12 hours. The study I showed you earlier with 3-hour saturation came out after this, so that'll have to be redone. And probably hemoabsorption would be discontinued before any renal support if your myoglobin levels come down. So the consensus view was that adjuvant hemoabsorption therapy with cytosorb is feasible, safe, and may be effective. Right? Quality of the evidence is still fairly low, and so there's really the need for adequately designed trials in a group that's difficult to do it in, but with defined and relevant outcomes. And of course, most of the places where you see rhabdomyolysis are in disaster management and trauma management. This is an excellent review. It's in the Turkish Journal of Emergency Medicine, but it's really remarkably good, talking about the management algorithms that the Turkish medical authorities did during their awful experiences during the earthquakes. And, one wonders that if we had a position where we could offer hemoabsorption to patients in disaster zones, whether that would translate to a benefit. Because often I see these patients taken out after 2 days of long lives and crushed, and you do wonder as to their longer-term outcomes. Anyway, go back to our patient. Despite needing renal replacement therapy, she made an excellent recovery, which, of course, is always good news. With that, I'd like to thank you. I hope you found that interesting. This is our new society, if any of you are interested in joining it. And I'm happy to take any questions. So, thanks. So I tend to do it 6 hours, right? Because you've got to give it time to get there. So 6 hourly, and then once you're up past 7, 7.5, then you keep that going. There's no science behind it. It's just, if you ask for it 3 hourly, it won't get done. If you ask for it 12 hourly, that's probably not enough. So 6 hours. Purely pragmatic. Anything else? If you come up and ask me, I'd probably...
What fluid do you choose and how much do you give?
So I tend to, we always do